Thank you, respected speakers and Dr. Tejpal and Dr. Neelam. Now, as we are already running behind the schedule by almost 40-50 minutes, so we are not taking a tea break and moving on to our next session, session number 5 on adult diffuse gliomas, unlearn the rules. So the first topic is diffuse lower grade gliomas. This session is supported by Medtronic. And I have our esteemed chairpersons, Dr. Syed Ather Enam. He is Professor of Neurosurgery and Professor of Neurosurgery at Sakar Khanum and Hussain Ibrahim Family Chair Department of Surgery at Aga Khan University, Karachi, Pakistan, and he will be joining us virtually. Dr. Randeep is not here, so we have our next chairperson, Dr. Prakash Chitalkar. He is Director, Cancer Center and Professor and Head Department of Medical Oncology, SAIMS, Indore.
Thank you. Thank you for the introduction. I've been given the onerous task of officiating for another chairperson who happens to be across the border, but I'm told he's on the line. And I'll not, without much ado, I'd like to begin the session on low-grade gliomas. Interestingly, Indu hasn't found any wonderful acronym for it in an artistic sense, but low-grade gliomas, we all know how, I mean, they are long-term and there are so many issues related to follow-up or not to, how long to follow up and when to re-surgery, etc. So we have 4 illustrious speakers. The first one among them is Dr. Aditya Gupta, who's at the Artemis heading the neuro-oncology, and he'll speak on early versus delayed surgery. Extent of surgery for diffuse low-grade gliomas. Have we found the right answer? Dr. Aditya Gupta.
So, good evening, everybody. So I'll try to wrap this up quickly as I can. Now, gliomas actually, from a neurosurgical side, a lot has changed in the past 20-30 years. The reason why I say that, and this is the original illustration by Dandy, as to how to remove a tumor that was stuck to the middle cerebral artery. So in fact, he would advance his hand along with artery forceps to clip the artery which was lying beneath the tumor. So from this time, we have moved quite a way ahead. Now fast forward to just 10 years ago, and I was presenting a debate 10 years ago on whether there is a role of surgery for this kind of a lesion in a 25-year-old lady with a single episode of seizure. Now this particular lady, you can see the fibers are very well displaced away from the lesion. And I still remember these slides which I made almost 10 years ago, debating whether surgery or no surgery and listing out sort of parameters and clinical situations in which I would favor surgery and situations in which I would not favor surgery. So there are obviously well-known prognostic factors which tell us within these diffuse lower grade gliomas, patient lies in the good prognosis side or the not so good prognosis side. So we have these grading systems which are actually more a guide to give radiation post-operatively or not, rather than a guide for us neurosurgeons whether to operate or not. Again, this very well-known study, which is familiar to, I'm sure, to all the radiation oncologists here. And again, this gives us more of a guideline to which lower grade gliomas to preemptively give radiation post-operatively, and maybe to some in which you could possibly avoid. Now, if I can sum up the problem with which the chairperson referred to, so the basic issue which we have with these diffuse lower grade gliomas, as they are called now, is that first of all, you have to understand they are incurable disease. The second thing we have to understand that this is a precancerous disease. Third thing you have to understand is because it is precancerous and incurable, the role of surgery at the time of diagnosis is unclear both to the patient and to the surgeon. And the other two adjectives which I will add is it's an uncertain disease. Now, the scan which I showed, I have seen similar scans in which a patient was followed up for 7 years and the imaging did not change. And I have seen patients with a very similar scan in which within 1 year there was a rapid progression. So I would say this is an uncertain disease, and because of all these, I would call it a frustrating disease to treat as well. So the 10-year overall survival, 35%, well, definitely more than 7 years most of the times. A relatively long progression-free survival ranging, again, wide range, 36 to 95 months. 50 to 75 transformed within 6 to 7 years of diagnosis. Lack of RCTs and large, even prospective observational studies. Further, lack of objective evaluation of extent of removal in many, if I may say, if many, most of the studies. Underestimation of the residual tumor present. So if someone were to conduct a RCT for this, and if was looking for a 20% possible difference between the two groups, you would need 250 patients for this RCT. And if there was only a 10% difference, you would need 800 patients for this RCT. So the question is, will this RCT ever be done? So to address the two basic questions, when to operate. So this is one of the earlier oft-quoted papers, which is basically about the role of early surgery. And sadly, this is in a group of low-grade gliomas, as they were called at that time, in patients with epilepsy. And the conclusion that it may be safer to defer surgery until progression was in this select subgroup of patients with epilepsy with low-grade gliomas, but sadly, it was extrapolated to the entire population of low-grade gliomas. Now, the very interesting paper, which I'm sure all of you are aware of, is this Jacola and later on the Horowitz paper in 2012 and 13, in which this is a retrospective comparison between two institutions in Sweden, one of which followed a biopsy and follow-up approach, and another followed an early surgery approach. Now, in this study, very interestingly, there was a distinct difference in the 5-year overall survival, which was statistically significant. So although a retrospective study, this was at that time one of the very, very compelling pieces of data, which in fact Professor Defoe quoted that this is a paper which will sort of be a very compelling piece of information for us to offer early surgery to these patients. Now, another very interesting paper published in 2019 in neurosurgery. This is a single institution retrospective review. Out of 300 some low-grade gliomas, there were 34 incidental low-grade gliomas. And the interesting result was the incidental ones had a longer overall survival compared to the symptomatic ones. So this is another piece of information which points to a support for early surgery, even in incidental low-grade gliomas, which is one of the questions we are trying to address. Now, the second question of how much to remove. So honestly, this takes me back to early 90s when I started my training. And the thing about gliomas in those days used to be, right now it sounds pretty paradoxical and even in fact, how should I say, hilarious. The thing used to be, if it's a low-grade glioma, why do you want to remove it aggressively? It's low-grade. And the same logic would apply to high-grade. Why do you want to remove it aggressively? It's high-grade anyway, radiation chemo needs to be given. So that used to be the thought process about gliomas, and actually a lot has changed. So one of the earlier papers in which, again, the thought process is that there is lack of high-quality evidence, and histologic sampling is the only thing which sort of merited any review of evidence, and this is a paper published in 2001. But after the publication of this excellent review by Sanai in 2012, later on it has been subsequently reinforced by many, many other publications, and specifically the Smith study from 2008 is repeatedly quoted, large size, 216 patients, so much so that more or less, I think very few amongst us would debate that there is a survival benefit of the extent of removal of these diffuse low-grade gliomas. Now, the things have moved forward in a way in which now most of us are doing a functional neuro-oncology. for these diffuse lesions, more and more of us are going for a functional guided resection, which on one hand enables us to be very radical, and on the other hand, it enables us to continuously monitor function and reassure ourselves that we are not harming the patient. The future, which has been presented by this paper from Italy, is using a combination of awake surgery, direct electrical stimulation, and real-time neuropsychological testing on the table. So with this kind of a combined multimodality monitoring of the neurological function, even during the surgery, there is initial exciting evidence of even higher extent of removal with a high degree of safety as well, which is the valuable thing. Now, another value add of surgery is establishing diagnosis. So look at this percentage, 30% of what appears as a lower grade glioma on imaging is grade 3 or 4. This is something which is a valuable data to guide our clinical practice. So if we were to, although there is compelling evidence to offer early surgery, but if you were to analyze and compare the benefits of surgery versus conservative management, considering all the talks that we have heard since the morning, I would say histologic diagnosis and today molecular diagnosis is the thing which surgery can concretely offer as one of the benefits. Of course, from offering a higher overall survival, a lower rate of malignant transformation, and of course, seizure relief and symptom relief. Conservative, I would say, is relegated to a small number of clinical situations in which it's very deep so as to be unresectable. Eloquent area surgeries, nowadays we always debate what is eloquent area, because most of the areas we can actually reach and remove the tumors very safely. So a couple of examples in which we were able to radically remove tumors from eloquent areas without harming the patient. So this is a dominant frontal lobe. Actually, the speech area was just about here on the preoperative functional MRI. And this is to show that sometimes in the deeper part of a low-grade glioma, sometimes you have to stop short and say, this part of it I am not going to chase very aggressively. Similar example where a little bit, which is very close to the external capsule and the basal ganglia, had to be left behind. So one of the saddest things I come across as a neurosurgeon is to find a residual at the surface. So that to me is very, very sad. In this day and age with all the technology, if you land up with this kind of a result post-operatively in which you've left a residual on the surface and not the depth, it's actually a sad situation. So I'll just show an interesting variation of a surgical technique which I've done over the past 5 years. And this is specifically not applicable to all lower grade diffuse gliomas, but those which are very discrete in their appearance. And they have a roughly what I call as a quadrangular shape. So the gyri, as we know, are perpendicular to the dural surface. And you have seen several such gliomas in which actually, if you think, you can actually conjecture that this is actually a single gyrus which is expanded with the tumor. So with this technique, what I found is, again, this is only for a select group of lower grade gliomas that are very discrete, at least on imaging. And I'll show a couple of examples. So this is pre-op and this is post-op. And I'll show you the surgical video. So this is a superficial frontotemporal grade 2 glioma. And basically what I'm doing here is I'm working within the arachnoid. And I'm not using any cautery, I'm not using any CUSA, at least in the periphery, because although we may think of CUSA as a very innocuous instrument, but to any neurosurgeon present here, if you ever touch the tip of the CUSA or the side of it, you will actually sustain a burn. It is so hot. So I don't believe in actually the CUSA tip even engaging the vessels around the tumor. And what you see here is I'm teasing away with the dissector the entire tumor and separating it from the vessels. Now, because I don't want too much handling in between, I am decompressing and taking away the tumor with the CUSA. But by and large, I am mobilizing this entire blob of tumor. And there is an MCA vessel which needs to be preserved. So you can see that I'm working around it, mobilizing the tumor and the involved virus. And of course, the deeper dissection from the deep white matter has to be with the CUSA. So teasing away this entire involved area and leaving this significant vessel which needs to be preserved is what we were able to achieve. And you'll see the artery that is preserved and pulsating in the surgical field. This is a brief video of the patient the next post-op day. Can somebody play this video? Okay. Yeah, so this is the patient with speech impact next day without any deficits. An example of a tumor which was very discrete, and in the lateral, the botocortex was just behind this very discrete lesion, and this is the post-op MRI. Again, a very quick video just to show you the dissection. So the involved virus actually is very clear to us when we open the dura. We see it has a very different color and vascularity. And again, I'm working inside of the arachnoid to tease away this tumor almost en bloc. And the reason why we are sort of quite confident is that on opening the dura, you do a navigation and you make sure that the margins of this gyrus correspond exactly to the margins of the lesion. And this is something which is quite quick. What I really like is that I'm teasing away all the blood vessels which are going to the surrounding gyri. I'm teasing that away from the surgical field using a simple dissector. And of course, as I said, once you do that, the deeper disconnection with the white matter actually has to be done with the CUSA. So in the interest of time, I'll skip this, show a couple of examples. This is dominant insular glioma, 5 years post-awake surgery and radiation therapy. Patient very, very functionally well preserved. So the trick is basically to be very safe on the patient side and be very aggressive on the tumor side. These are all the intraoperative adjuncts which you've heard in the morning talk, so I won't go into it again. How much we can remove in a given case is not something we can come out with a dictum. It depends on case to case. I would basically like to be in one of these three zones. So either a gross total dissection, a functional guided supramaximal resection, in some cases, anatomic resection, especially, for example, if it's a temporal, medial temporal pathology. So I would love to do a radical temporal lobectomy, including an amygdalohypocampectomy. Some gliomas are definitely unresectable, but at the same time, as I said, there are many in which we can do a very good job with surgery. So this is one of my recent cases, and this is a post-op MRI done just maybe a couple of months ago, showing a very good result of a dominant insular glioma with no post-operative deficits. So this is my end slide. So I would say finally that treatment decisions in these diffuse lower-grade gliomas are still very unclear and uncertain because of the nature of the disease. I would say there are very few reasons not to offer early surgery at the present time, which is what I would say is our current philosophy. And extent of removal is an important predictor of survival. That is what the compelling, overwhelming evidence of the scientific literature supports. But finally, I think it is the clinician's judgment on the table as to how much they can remove in a given case. Thank you.
Thank you. Thank you, Dr. Aditya. I think one quick question we can take because there will be no panel. Any questions? If there is none, shall we move on? Thank you very much, Dr. Aditya. And the next speaker is Dr. Epari Sridhar. He is the head of the neuropathology at Tata Memorial Actric, and doing his long experience in the neuropathology field. And he'll speak on the evolving role of molecular landscape in the diagnosis of adult diffuse glioma, embracing uncertainty. Dr. Epari.
Thank you. I must thank the organizing team for choosing this topic. I have to admit that I found it extremely challenging to take this topic, as embracing uncertainty about the molecular landscape in adult diffuse gliomas.
Dr. Epari, can I hold you for a minute? We welcome Dr. Syed Athar Inam from the Aga Khan University, Karachi. He's also joined me as a co-chairperson, and I think we'll introduce him again and involve him in the next intervention. Thank you.
I hope I will stand up to the expectation of the organizing team for this talk. So I took a little bit liberty to change the topic, modifying the topic to further, so saying that evolved molecular landscape in the diagnosis of adult diffuse gliomas and evolving role of molecular landscape, not in the diagnosis, but at least in the management of diffuse glioma. Embracing uncertainty or certainty, we will see. Well, it's nothing new to this audience anyway. What you are seeing in the pictorial representation of the WHO books, actually edition, they are actually truly reflect the change in perception or defining diffuse gliomas. It was an era from histological to histomolecular era, and the approach from the microscopy to taking some high-end throughput genetic testing using artificial intelligence methods to delineate the entities. This is what the evolution of the diffuse gliomas. But the thing which is really changed or paradigm shift in understanding the diffuse gliomas has occurred with Parsons' discovery of IDH mutation, and subsequently in a large cohort of the tumors shown, like, had the different distinct biological or clinical groups of having tumors with IDH mutation, without IDH mutation, and or in the mutant group with 1p19q co-deletion and without the co-deletion, which is seen in these different graphs, and this must have been seen, shown you earlier in quite a number of times. Similar kind of study has been shown with additional marker of TERT mutation with only triple. Is called, Dr. Jalali always used to say the triple test type or triple marker like IDH mutation, TERT mutation, 1p19q. Irrespective of the histology, we can probably get into a good biological group or the bad biological group. So this is the essence which serve the basis of redefining or reorganizing the diffuse gliomas. And these kind of gene alteration, and also with multidimensional and multi-parameter approach, has shown this diffuse gliomas falling into three different broad clusters. Interestingly, these three clusters had fallen as one as oligodendroglioma, the other is the IDH mutant astrocytomas, the third is GB or IDH wild type, three different clusters. So that served the basis of identifying adult diffuse gliomas into distinct molecular groups, which was initially as was preluded in the updated 4th edition as thing. However, it has been further refined or it has been proven or kind of saying that it has got three distinct groups in the current adult diffuse glioma. What are they? One is astrocytoma IDH mutant. Mind you, in the current classification, this one group is one. And this grade 2 and grade 3, grade 4 are considered as intratumoral grading subtypes. It's not a distinct subtype, whereas in the previous classification, grade 2, grade 3, and grade 4 tumors were considered to be as a distinct entity. But current understanding is IDH mutant astrocytoma is a single group with different grades. Similarly, oligodendroglioma is one broad group, different grades. And the third subset is IDH wild type tumor, which is called glioblastoma. So this we all know, we have come across in different talks, in surgical talks, radiation talks, as well as pathological talks. What are the key genetic alterations in the classification of adult diffuse gliomas? Yes, we cannot now say without talking about IDH 1 and 2 mutation that stands at the highest. The second is the loss of function alteration of the ATX gene, which we histologically see as loss of expression for ATX protein, 1p19q co-deletion, p3 mutations, EGFR amplification, and 7p gains, you can say 7p gains, chromosomal 9p21 or CDKN2A loss, chromosome 10 loss. These are the major molecular alteration which can define these three broad groups into as of understanding. So there are certain kind of what you can say positive and negative correlations which is very interesting to see. All IDH mutant tumors either harbor 1p19q co-deletion or p3 mutation. There are two broad groups of IDH mutant tumors, but not both. So it is not possible to have both alteration. When I'm saying co-deletion, mean it is the loss of full arm of chromosome 1p and 19q. What we use the fish as a surrogate, it is only as a proxy, it detects only a portion of the chromosome arm. So you should not. So when you have an ATRP3 mutation, it is unlikely or most likely it will not harbor 1p19q co-deletion. These are two broad groups. This is first rule in adult diffuse gliomas. And interestingly, 1p19q co-deletion is almost always associated with TERT mutation, but never associated with loss of ATX gene function. So ATX gene function, loss of ATX loss and TERT promoted mutation are two mutually exclusive groups. This is the second rule. And most of the p53 mutation are associated with ATX gene mutations also. And IDH1, IDH mutant tumors can also have TERT mutation. So TERT mutation is not used as a surrogate for anything. It is an independent molecular marker. It has to be assimilated in association with other alterations. So if you have an IDH mutant with TERT mutation, it has a different meaning. TERT mutation without IDH mutation has a different meaning. So either TERT promoter mutation or ATX mutation is detected in vast majority of gliomas, mean almost all adult diffuse gliomas, either they show TERT promoter mutation or they show ATX loss. What does it tell you? That tells you that telomere mediated tumor gliomagenesis is a dominant feature in adult diffuse gliomas. So it has to be there. Because of these tight rules, it allows us these adult diffuse gliomas to get divided into three broad groups. One is IDH mutant 1p19q co-deleted, which is p3 not mutant. That is the oligodendrogliomas. The other subset, IDH mutant p53 mutated, which are also associated with ATRX gene alterations, are astrocytomas. The third one is IDH wild type or no mutation of IDH, which can have TERT mutation also. These are predominantly glioblastoma. So now you understand this is what the evolved molecular landscape of adult diffuse gliomas, which is three distinct biological groups which can be identified. To get this, it is in the updated 4th edition WHO classification. A schematic picture has been suggested to apply in routine practice using as a bipartite way of distinguishing based on ATRX loss and 1p19q co-deletion. This schematic picture can address almost like 95% of diffuse gliomas, adult diffuse gliomas, especially the low-grade gliomas, to either classified into two distinct groups. There are exceptions, more probably in 3 to 5% of the cases, ATRX gene may not be altered. So coming to each indivisible entity, like what is IDH mutant astrocytoma? When somebody says IDH mutant astrocytoma, it denotes that 1p19q non-deleted. So it need not be specified. So what is understandable is 1p19q non-co-deleted are equivalent to the astrocytic tumors. This is what. So it's a non-co-deleted tumors. Most common mutation which is observed in adult diffuse gliomas is IDH1 R132H type of mutation. Thankfully, this can be detected by simple laboratory technique of immunohistochemistry. So when you get negative for this IDH1R132H, it should not be automatically called as wild type mine. This is only negative for that mutation. So if you want to prove that in certain circumstances or certain compelling histological features, or maybe if there is an ATRX loss, you need to subject to the sequencing to confirm whether to have presence of IDH mutation present or not. Okay, that is one thing. And to usually adult IDH mutant astrocytic tumor, they usually harbor P53 and ATRX protein, ATRX gene alterations. Rarely, in instances where we have seen like an astrocytic tumor or reported an astrocytic tumor with an intact ATRX protein, that means retained expression. Interestingly, what it has been observed, like these subset of tumors where ATRX protein is retained, show a little worse prognosis as compared to a typical IDH mutant and ATRX loss or mutated astrocytomas. They are currently graded into grade 2, 3, 4. One more addition is, it is conventionally used to be graded based on the histological features. In this classification, one molecular alteration has been incorporated into the grading criteria, that is presence of homozygous CDKN2A/2B gene deletion. This is also a feature of defining criteria for grade 4 IDH mutant astrocytomas. So what is it like? We knew that it has been started IDH mutant saying that this is a tumor which can progress from the low grade, accumulate subsequent alteration and presence as the kind of a transform sort to grade 4 tumor. That was a notion which was thought. But what is the current understanding? Interestingly, studies have shown that the de novo IDH mutant grade 4 astrocytoma and the evolved, the transformed grade 4 IDH mutant astrocytomas, they do not show any significant difference in molecular alteration. Neither they do not show any differences in the epigenetic features also. So what it has been thought like, which we used to think that IDH mutant transform grade 4 are different from IDH mutant de novo grade 4 tumors, and they are not different. So based on this observation, it is thought like it is the histological transformation induces epigenetic shift and gives a signature of IDH mutant grade 4 astrocytic tumors. As this has been observed here, you can see in this study by Koshno et al., the German group has shown like even in methylation also, they could see a distinct epigenetic differences between the grade 4 IDH mutant tumor and the grade 3. This cluster is the grade 3 and this 4. So they had shown difference. That means like evolved and de novo are the similar. And also they showed two interesting observations like CDKN2A to B homozygous deletion, even in the grade 4 tumor, with homozygous deletion, without homozygous deletion, have a different survival rates. That means like even in grade 4 tumor, homozygous deletion confers a worse prognosis. Whereas, interestingly, KM2D gene mutation, which is actually initially described in medulloblastomas, and this thing has shown to induce a favorable links. However, this finding has to be kind of correlated in a larger study, but it has shown to be favorable. So this embraces again an uncertainty among the IDH mutant grade 4 tumors. Yes, is it good enough to just to have an IDH mutation knowledge? No, probably we need to have further, even in grade 4 tumors of CDKN2A homozygous deletion. And in addition to that, what is it like? The supratentorial are the commonest occurrence of IDH mutant tumors. But of late, there are, because of the advancements of the techniques or NGS-based method, they have identified a small subset of infratentorial IDH mutant tumors as well, glioma, in adult diffuse gliomas. What are they? Are they similar? No. The supratentorial and infratentorial IDH mutant tumors are biologically different tumors. The typical supratentorial IDH mutation is the most common mutation, is what you pick it up on the immunohistochemistry, is IDH1 R132H. Whereas infratentorial, most of the time they harbor non-canonical type, then other than 132. So you may not pick it up on the routine surgical pathology. And also interestingly, the chances of ATRX gene mutation is low in infratentorial. So you may not get loss of ATRX. So there is no way surrogate to pick up the infratemporal IDH mutant based on histology. These are picked up by only if you have used the sequencing method to demonstrate. The frequency of MGMT methylation is low in infratemporal as compared to this, and also shown to a significantly reduced overall survival rates. Can I take a couple of, only 1 minute? Okay. Okay. So oligodendrogliomas, I will not touch upon the conventional knowledge, what it is there and all. It is very well proven that oligodendroglioma are biological subgroup. But interestingly, what it has been observed, like they are shown to have mutations in CIC and FUPP protein genes, which are tumor suppressant genes, and of very high frequency in oligodendrogliomas, exclusively 1p19q co-deleted tumors, oligodendrogliomas, and also shown to be a worse prognosis. But we don't test these in routine oligodendroglioma, put it everything as a one big common basket of oligodendroglioma as a good biological subgroup. They do have P10 and PIK3 mutations also. So what is this among this lower grade IDH mutant diffuse gliomas? There are some emerging prognostic marker beyond what it has been established, especially in case of IDH mutant astrocytomas. They're shown like gains in CDK4, MYC gene gain, MYC or MYC-M genes are shown to be worse outcome, and also a small subset with MMR protein mutation or a loss of function also shown to be a worse outcome. The PDGFRA PIK3 mutations has also shown a worse outcome. CDKN2A deletion we have seen, we know in grade 4 we are seeing, but in grade 2 and grade 3 as well, but defining feature for grade 4. And total CNV is like aneuploidy, like copy number variation of more than one chromosome associated with it, also shown to be of worse prognosis. Interestingly, isolated 19q deletion in an IDH mutant astrocytoma has shown to be a little bit better prognosis. We don't know much, but this is based on the different studies. Similarly, for oligodendrogliomas, simultaneous polysomy of 1p and 19q has shown to be worse. Similarly, for the PIK3 related mutations are shown to be worse, and CDKN2A deletions as well. So, IDH, coming to IDH wild type gliomas, current classification identifies only one type, that is glioblastoma. So, what is it like? You know, the criteria which has been said, like having a typical histological features of grade 4 and or either of the molecular markers of TER promoter mutation, EGFR amplification, or combined chromosome 7 gain and loss of chromosome 10. So there is, as of now, understanding there is no IDH wild type grade 2 and grade 3 tumors. But is that true? What is this? This subset shows that most of the adult IDH wild type of gliomas, irrespective of histological features, they show the molecular features of glioblastoma, that is either TER mutation or EGFR amplification or the combined chromosome 7 and 10 alteration. But whereas a subset do not show these features. And when they might be associated, even I'm not talking about pediatric, an adult type, they can show MIB amplification or a beat of V600 alteration, which can associate a longer survival rate. And few cases, like especially in the cerebellar, they're shown to be more closer to the high-grade astrocytomic pyeloid-like features in methylation. They also shown to be better. And other NF1SS mutation also shown to be. So, histologically low-grade IDH wild type are heterogeneous. They also exist some good biological groups. This is the current. And this is an interesting, I'll take this. This is an interesting study which has been shown how the TER mutation, when they applied in a cohort and applied the criteria of 2021 criteria of IDH wild type gliomas in this, they observed that if you see in this picture, maybe I'll say, observe that TER promoter mutation alone does not confer any kind of worse prognosis, especially in grade 2 histological IDH wild type tumors. So there is a doubtful application about it. I'll skip this slide for the interest of time, because these are all the list of genetic alteration which are described in reported in IDH wild type. They are pathway are kind of associated with this. Okay, among the IDH wild type, I just wanted to say that there's a recent discovery, this is an identification of a subtype, which is FGFR3 and TAC3 fusion associated subtype, which has shown to be favorable. And current understanding is like IDH wild type gliomas are a heterogeneous group, constitutes almost like 7 distinctive molecular subgroups. Of this, the PDGFRA amplified group are considered to be best prognosis relative among the IDH wild type. I want to highlight this in this reason that what we know that IDH wild type glioblastoma thinking as a single subset of the disease is a multiple subsets of the disease. I'm almost done, sir. So just to re-emphasize, third promoter mutations are common in across multiple molecular subgroups of IDH wild type glioblastomas, and isolated third mutation, we need to be careful about utilizing that as a prognostic marker. So just to say that, to sum up these things about what are the uncertainties we are embracing toward it, the de novo and devolved IDH mutant grade 4 astrocytomas are biologically similar, unlike what we used to think. It has been proven on different epigenetics and genetically. Supratentorial and infratentorial IDH mutant tumors are not the same. They are different biological groups. Not all oligodendrogliomas are uniformly one molecular subgroup. They do have some warfare groups, especially the Notch mutation associated group. And IDH wild type gliomas are not a single entity. They are itself an heterogeneous entity. Thank you, and I sincerely apologize for skipping the time.
Thank you, Sridhar, for an excellent section. For the interest of time, we have to wind up. I'd like Professor Syed Athare now to make a comment, if possible. Is he online?
Thank you very much. We are running short of time, and I think we need
Okay, I'll invite Dr. Shaleen Kumar. Oh, he's there. Dr. Syed, yes. Welcome, Dr. Syed.
we should continue, please. We should continue. We're short of time. Thank you very much, Dr. Sridhar.
Hello. Yeah. Hello, Dr. Syed.
As I said, Professor Chitalkar, we should continue. We're running short of time. So Professor David Lewis is also waiting. So let's proceed with the third speaker, and I will just say thanks to in the end. Please go ahead.
Thanks. Dr. Shaleen Kumar, Professor of Radiation Oncology in Lucknow and a very old friend since the Tata Memorial days. He'll speak on predict, prevent, and personalize when, how, and why to radiate a diffuse low-grade glioma. Dr. Shaleen Kumar.
Thank you, Chairperson, sirs, and ladies and gentlemen. Grateful to the organizers for the opportunity to present a view. I have to say that the landscape of this presentation is quite is going to be quite a challenge. After these very exhaustive talks by Dr. Chitalkar and Dr. Aditya Gupta, let me see if I can make some sense out of how to disentangle trials that have been done 2-3 decades or a decade ago, usually by reclassifying archived material into different along these classifications, the current classification of WHO classification, and see whether we can suggest what might be the way forward from a simple group like saying it's an oligodendroglioma, but there's so much of sort of heterogeneity. So let's see what one makes of it. So the roadmap is just talking about what might be the recommendations for the therapy of lower grade gliomas in the context of the 2021 classification, and look at the relevant clinical trials, which might give us some clue. Very briefly, a slide on radiotherapy techniques and just a slide on neurocognition. So we've seen this slide, and we understand very clearly that IDH mutant, low grades, good prognosis is IDH mutant, and if they have a co-deletion, then they are oligos, otherwise they are diffuse astros, and the wild type are binned into the glioblastoma. And these are the 3 categories which Dr. Chitalkar has very well expressed. So what are the lower grade gliomas? So when you have IDH mutation and co-deletion, you can have grade 2s and grade 3s. And if you don't have the 1p19q co-deletion, then they're astros. And now we've just had, and I'm thoroughly confused what to do with IDH mutant CNS grade 4, because I thought very simplistically that this is a transformed low grade en route becoming a high grade, and that's the explanation. But obviously, that is not what our understanding is now. So these are generally the lower grade gliomas, certainly the grade 2, grade 3s, oligos, and the astrocytomas, and possibly the IDH mutant also behave and are treated accordingly, similarly. So now what's the recommendation? This reference is useful. These are not my recommendations, it's published, and I'll try and make some sense of it. So when you look at grade 2, either oligodendros or grade 2 astros, what should be the radiotherapy dose? So it's 54 gray in 30 fractions. How do we know this? We know this because in the RTOG 9802 trial, which I will elaborate very shortly, they had where there was a poor prognosis low-grade glioma, or in other words, a glioma that the neurosurgeon was not happy to follow. This could be subtotal resections of any age or anybody more than 40. Subsequently, of course, we've got the Pignati scoring and all that. So they got randomized to radiotherapy or radiotherapy plus PCV, and the radiotherapy used in that was 54 gray. And so that was the basis. And in any case, there isn't a dose response relationship between 45 gray and 64 gray, 64.8 gray. And we'll just quickly talk about those trials very fast. Now, what to do in oligos? Because that was a trial on low-grade gliomas, and we had both astros and oligos there, grade 2, they used PCV, and so that is regarded as a reasonable option. It's a different matter that the North American PCV is different from the MRC PCV that we often use in this country, or at least in Tata Hospital. We've been doing that. We do that in our place in Lucknow. The dose intensities are different, but I won't wade into that area. That's rightfully that of the medical oncologist colleagues. And interestingly, it's also adjuvant temozolomide as used in the Catman trial, that is concomitant and adjuvant temozolomide in the non-1p19q deleted cancers where the non-1p19q deleted oligo astrocytes, malignant gliomas, and there it was seen that temozolomide was also effective, and therefore this is the evidence base. What to do with astros? So you can give either radiotherapy followed by procarbazine for a year, 6 cycles, for 8 weeks, 6 cycles, 8 weeks, or you can give temozolomide. Now let's come to the grade 3 anaplastic oligodendroglioma. So now this is a higher grade, and in this trial, anaplastic oligodendrogliomas were randomized to receive just radiotherapy or radiotherapy plus PCV. And in the EORTC, the PCV was given posterior after the radiotherapy. And in the RTOG, it was given, and in the RTOG trial, it was given anterior. So I'm just in 6 minutes. Oh, really? Okay, so fine. We come to now. What about the anaplastic astrocytomas grade 3? So based on the Catman trial, it's 59 gray and adjuvant temozolomide. Now there are a group of patients who are, IDH oligodendrogliomas, IDH mutant, co-deleted, grade 2, and initial therapy may be deferred. And that's what Dr. Aditya Gupta talked about. some patients who can be potentially followed up initially through serial imaging and radiographic and symptomatic progression, and then intervene subsequently. So the first question that needed to be asked was that, does radiotherapy actually work? And so there were these patients in the EORTC trial where they had these low-grade gliomas, and there were patients who were randomized to receive early radiotherapy or radiotherapy at progression. And interestingly, there was no difference in overall survival because there were crossovers and salvages, but fundamentally, those who received radiotherapy early had a far greater probability of being free from progression compared to those who received delayed radiotherapy. So, and progressive disease results in other sequelae, such as poorer seizure control. And in any case, those who hadn't received radiotherapy received it at progression. So is radiotherapy necessary for low-grade gliomas? I think the short answer is yes. So should we give it? Well, yes. All right. There is no dose-response relationship between 45 to 64.8 gray or even higher. And I won't dissect these trials, but you can take my word for it. The resources are here. There are actually 3 trials, including a hyperfractionated trial also. Okay, so now, what happens in the high-risk low grades? So if a neurosurgeon decides that the patient has had a complete resection, the patient will go possibly into observation. Otherwise, if there is a subtotal resection at any age, or if the patient was older, then in this trial, they randomized them to RT or PCV. And what they did was, they noticed that patients who had, the enhancements were worse off, and by 5 years, the RT-PCV arm was doing better, and by 12 years, it had definitely widened. Now, all groups, virtually all kinds of patients had improvement in survival, head-on those who had PCV, including the grade 2 oligodendrogliomas, the grade 2 oligoastrocytomas, and those who had the IDH mutation, but not those who were the grade 2 astros. So the secondary analysis was that RT plus PCV is better for all IDH mutant subgroups overall, grade 2s oligoastrocytomas, but not good enough for the grade 2 astros, which are IDH wild type. Likewise, you have for the anaplastic oligodendroglial tumors, when PCV is used, then it, in these 2 trials, there is a clear separation as well. Now, in the Catalan trial, so clearly, if you have one P19Q co-deletion, it's chemo-responsive, chemosensitive, as well as radiosensitive. Now, if you don't have the one P19Q co-deletion, then those were the patients who were then randomized into receiving either radiotherapy or concurrent temozolomide or adjuvant temozolomide, or like the stuprogene, concurrent and adjuvant, all 4. And what we're seeing is that in these patients, if you don't have one P19Q, then it is not necessary that the rest of the gliomas are, the rest of the tumors may have IDH mutation. So about a third did not have, and 2/3 did have. So what is noticed is that across the entire mixed cohort, it was only the adjuvant arm that actually had adjuvant PCV arm that, temozolomide arm that had an effect, and not the concurrent arm at all. Okay, now this is about, I'm wading into the space of Dr. Aditya Gupta, where he looked at who could be observed. He did talk about the good prognosis ones. And so Patients who were younger and had a complete resection, or any age who had incomplete resection, those who were younger and a neurosurgeon had determined, they were observed. And this is Dr. Aditya Gupta has shown us these kind of photographs. And the patients were followed up. And what we noticed was that the older patients who had astros or large pre-op tumors progressed, and these were all the prognostic criteria that are harbingers of progression, as well as the Pignati scoring system, which was talked about. But all this has now been upturned, completely standing on its head by the molecular classification that we now have. Coming next to the next story is, what kind of radiotherapy volumes shall we use? Well, if you look at trials done between 86 to 94, we used CT scans and later MRIs and used small margins to blockage, 2 centimeter margins up to the blockage. Radiation oncologists would understand this, and that was a small margin. And currently, right, so I'm done. This is the second last. So, whereas in the more recent trials, we've been using larger margins. Now, fundamentally, the point is that the margins may not be so critical. They're important without doubt, but these have all used either very conventional techniques, or they've used 3D CRT or IMRT. Nowadays, the standard treatment is at least IMRT, and you can use any degree of complexity and conformality, and that is all very good and appropriate in context. Neurocognition has been attributed to radiotherapy often, but it's important to know that in this French prospective study, patients had, after they received radiotherapy, randomized to receive a prospective study, those who had radiotherapy, they had a transient decrease in their cognition, which returned to baseline at 12 months. In this Dutch multi-center study, where low-grade glioma patients were compared with those with NHL and CLL and healthy controls, what they found was that low-grade glioma patients scored worse compared to NHL and CLL inherently, and they were worse compared to healthy controls. But those with radiotherapy were no worse than those without radiotherapy. And the increase in dose was associated with diminished memory, particularly with large fraction sizes, but antiepileptics also resulted in it. So besides radiotherapy, there could be the interventions, the disease, and other things that are responsible for poor neurocognition that follows radiotherapy. So finally, and this is by the same group, that they have looked at a 1-year outcome and shown no difference whether there was radiotherapy or temozolomide, but 1 year is hardly any time. You need 10 or 15 years, and that's when it really matters. So I don't think this issue is settled, but we suspect that radiotherapy does cause a worsening, and therefore conformality, better conformality is advised. So what are my personal conclusions? I think there is a great possibility of personalization. It's difficult to tease out historical data, even though you've recategorized it and apply it, but there is good evidence that what works and what doesn't work. And more importantly, there's no point treating patients with therapies that don't work. Also, many of us are working in sectors where we just provide service, and even if we cannot contribute to research actively, I thought it might be a good idea if we at least start tissue banks, as some hospitals have. Tata Hospital, I'm aware, does do it. And of course, be mindful of stage migration. When you rebuild the previous astros and oligos into these refined techniques, then across the board, even without any real intervention coming, you have the well-known Will Rogers phenomena, and everything will seem to be much better. One just needs to be mindful of that. I thank you for your attention.
Thank you. Thank you, Dr. Shaleen. Sorry for cutting you off. I will quickly move to the last speaker in the session, Dr. Vijay Patil. Associate Professor, Medical Oncology in Tata Memorial Hospital. And he speaks on, are these two souls traveling in the same path? How to choose wisely between temozolomide and PCV? Dr. Vijay.
Yeah, so thank you organizers for this opportunity. As the slides are coming up, what have we cleared up till now? You see a low-grade glioma, operate, maximum safe resection. Grade 2 low risk, you can observe. Grade 2 high risk, give radiation, needs chemotherapy. Grade 3 needs radiation after surgery, needs chemotherapy. Which chemotherapy? Well, let's discuss this in the next 10 minutes. Now, what is the importance of PCV? The importance of PCV was in this RTG 9802, you saw that there was nearly 25% increase in PFS at 10 years and nearly 15 to 20% increase in overall survival at 10 years. Now, those of you who practice adjuvant chemotherapy would know that a medical oncologist gives chemotherapy in lung for a 4% survival benefit, adds chemotherapy in head and neck cancer for 6.5% survival benefit. So these numbers are huge. There is no decision here. You need to give PCV when you look at this data, as opposed to if you're not going to do anything. Let's look at this further, and I won't delve this with in detail because Dr. Shaleen Kumar sir has already dealt with this. You look at any molecular subtype, 1pq, 19q correlated. You look at if it's IDH mutated, they benefit. So IDH mutation benefits. If it's IDH wild type, it does not much benefit with addition of PCV. This was again discussed in an ASCO abstract after a few years after publication of a paper, which again clearly showed the same thing. If it's IDH wild type, it doesn't benefit. IDH mutation, if it is correlated, the benefit is to a large extent of adding PCV. If it's non-correlated, then there is a benefit, still there is a substantial benefit. Same thing goes with the overall survival. So we all should be giving PCV. What's the need for discussion? The need for discussion is because it leads to an ample amount of adverse events. Grade 3 and 4 side effects of 50 to 60%, especially myelosuppression, would be seen with this regimen. If you look at this schedule, it's an 8-week schedule, and which requires cycling that is 2 months, 6 cycles. It takes 1 year to give this schedule. Pretty complicated schedule. This is the RTOG schedule, where you do procarbazine from 8th day to 21st day. CCLUs is placed on some day. VCRs have been placed on some days. And believe me, if you are given PCV, it's very difficult to rigorously follow this schedule. We give it routinely in one of the studies. I'll be sharing the data today, but it's difficult to deliver this schedule. So obviously, we go back and see at our other friend, which comes as a savior for us in GBM, temozolomide. Do we have some data to say that in low risk it can work? This data from RTOG 424. But I would caution you here. If you look at the 5 year, this is not an randomized study. The upper curve is of overall survival and the lower curve is of progression-free survival. If you see the 5 year PFS is around 50% and the 5 year overall survival is around 65%. Let's quickly look at the curve for RT here. And if you look at the curve for RT, the curve doesn't match the curve for PCV. It actually matches the curve for RT. Also, please note that the separation for PFS happens only after 3rd to 4th year after PCV, and the separation for overall survival only happens after 4th to 5th year. So it would be, in my opinion, at present premature to say that temozolomide can easily replace PCV. There are 2 globally going on studies. One is done by the URTC, second is done by the Tata Neuro DMG group. And we'll have to wait for these results to be very confident that temozolomide will have the same efficacy as is PCV. This gets reflected in the guidelines. You would see WHO grade 2 high risk. NCCN would say PCV is a preferred regimen. So is in the WHO grade 2 for IDH mutant astrocytoma, it would again say PCV will be the preferred regimen. This was the conclusion after the RTOG 9802 talk, which was given in subsequently in ASCO, in which again they said that PCV is a preferred regimen, but yes, temozolomide remains an alternative regimen. And why are we so fixed with temozolomide? It's oral. It's an easy schedule. It has less adverse events. And we know that in GPM, in adjuvant setting, PCV never worked, but temozolomide did work. So it actually tamed the better devil. So we think that it might be able to tame this devil. So the question is, can we replace PCV with temozolomide? This question will take another 10 years to answer because I'm very sure that even the TMH study, even after it's completed recruitment, it will take that much time for us to answer the question. Even the URTC will take that much time to answer. So the actual question is, can we deliver PCV in India safely? And for that, I'll take back to this study, which is an ongoing study in Tata Memorial Hospital. It's a phase 3 randomized study comparing temozolomide versus PCB. And 217 patients had to be recruited. We are nearly come to the 50% of the recruitment. What I'm going to show you is the data of first 50 patients for which we have 1 year or more years, so that I can talk about the compliance and quality of life of this patient and adverse events of these patients. You could see this was a 2:1 design, so more patients in temozolomide arm versus PCB. And you could see at the end itself, the completion rates were much higher in temozolomide than those with PCB regimen. This is just to compare. The baseline characteristics were exactly similar between both these two arms, so we can actually go ahead and compare the toxicity data. And this is the toxicity data, and I've shown you the whole table here. What it's striking is myelosuppression and febrile neutropenia are very high in patients who receive PCB. Does that impact the quality of life? Surprisingly, it didn't impact the quality of life of patients, and we had data for nearly 2 years of most of these patients for quality of life, and I have shown it in a nutshell that none of the p-values were significant. If you look at the global quality of life in these patients, remember these patients got randomized at baseline. So after baseline, they received radiation for around 2 months, 1 month of break, and then temozolomide or PCB for another year. So we please focus on the first 14 to 17 months of treatment. This is the time when they are actually receiving the treatment. You could see that the global health quality of life was nearly similar. Yes, but what we saw is a higher amount of fatigue does steepen, though it was not statistically significant in these patients. A higher amount of financial difficulty slightly scores are on the higher side in temozolomide arm. Nausea and vomiting slightly higher scores on PCB arms. And neuropathy, and which Dr. Jalali would agree to me, we always discuss, do we actually need VCR in a PCB regimen? If you look at VCR actually never penetrates the blood-brain barrier. It's still given us classically, but we actually don't know what its role is. Did it lead to impact on compliance? The median number of cycles which we needed to give was 6, and we actually could complete 6 cycles in most of our patients. If you could see the those delays were seen in nearly 81% of patients of PCV. You could see some delays which are higher in temozolomide, and this is because quite a bit of the study actually ran during COVID pandemic. So the patient had delays because of not availability of temozolomide during that time. If you look at the modification, 70% of patients on PCV required modification, and that had largely due to myelosuppression and transaminitis, which came in this patients. If you look at the tables below, completed planned number of cycles, you could see that a higher amount of patients on temozolomide completed all cycles, as opposed to that with PCV arm. How did each of the cycle went on? We did good. CCMA, median number of cycles was 6. Procarbazine, the median number of cycles was 5.5. How does this compare with the RTOG data? It compares favorably with the RTOG data, where the median number of cycles for procarbazine was 3, CCMA was 4, and this was 4. So we actually did far better than this. But remember, this was a dedicated team of neuromedical oncologists, neuroradiologists, neuroradiation oncologists, and neurosurgeons who all were involved in this management of these patients. So what I could say is, today actually I feel there is insufficient evidence to just change temozolomide to PCB. We need to wait for the study results to come. However, if an ecosystem of a vigorous neuro team is not there, it's better to give temozolomide than to harp upon on PCB. PCB RTOG is delivering in expert hands, but you would have adverse events, and you need to tackle those adverse events, though they do not change the quality of life of the patients. I need to thank Dr. Rakesh Jalali sir, who was the brain behind this study. I need to thank Dr. Tejpal sir. I need to thank Abhishek and Archo, who are behind me to take every patient of grade 2 and grade 3 which comes to our institute in this study, and the whole of Neuro DMG, without which this study could not be done. I need to thank a lot of funders which have funded this study and other studies of mine. With that, thank you for your attention.
Thank you. Thank you, Dr. Patil, for very short, succinct presentation, respecting the time. I now invite my co-chairperson, Dr. Syed Athar Inam, to quickly summarize the session and give his comments before we move.
Thank you very much, Professor Chitalkar, and I thank the ISNOCON for giving me this chair position for this session. This was a wonderful session. We learned about practical aspects of low-grade glioma, surgery by Professor Gupta. I can relate to that as a neurosurgeon. The difficult task of trying to cover the unknowing landscape of molecular Biology by Professor Sridhar was also wonderful. Professor Kumar then enlightened us about the nuances of radiotherapy. And finally, a very thought-provoking talk by our last speaker, Professor Vijay Patil. Once again, I thank ISNO and Professor Rakesh Jalali particularly. I have made PASNO following ISNO, so I owe a lot to ISNO and to all the professors and all the people who make ISNO such a successful entity. Thank you very much.
Thank you, Dr. San. Thank you. So I hand over to the organizers. Thank you very much for the attention.
Thank you, sir. Thank you, speakers and chairpersons, for such a wonderful session. So there's a slight change in the schedule. We'll be moving on to the next session now, which is the Guha Oration, and then after that we'll come back to the glioblastoma session. So may I please invite the chairpersons, Dr. Tejpal Gupta and Dr. Kumar for the Abhijit Guha Oration.
Thank you. So now we come to the App Guha Oration, and may I request Dr. Chitra Sarkar to please come on stage and introduce the App Guha Orator. Ma'am, please.
Can I have the slides? Good evening. Welcome to the Abhijit Guha Oration, which we look forward to every year as a very important event of the ISNOCON. It is my proud privilege and honor today to introduce to you all the orator of 2022, Professor David Louis. He is the Benjamin Carson Professor of Pathology at the Harvard Medical School, Pathologist-in-Chief at the Mass General Hospital, Chair of Pathology at Brigham and Women's Hospital, Inaugural Chief of Enterprise Pathology at Mass General Brigham since 2022. Under his chairmanship, the MGH department has become a national leader in molecular diagnostics and pathology informatics, leading to a novel initiative in computational pathology. His clinical neuropathology practice and research focuses on brain tumors, particularly molecular diagnostics and glioma classification. And he is a pioneer in this field, and the WHO 2021 classification, which is the theme of this of our conference this time, he has been the pioneer in this. His group first demonstrated the molecular approaches which could subdivide malignant gliomas and predict the therapeutic response, leading to the worldwide adoption of molecular testing for the glioma management. He has published more than 300 original articles, reviews, chapters, and of course, books. Most importantly, he has served on the 2000 WHO Committee on the Classification of CNS Tumors, co-chaired and was the primary editor for both the 2007 and the 2016 WHO classifications. We have all heard of the C impact in between the 2016 and the 2021 classifications, which formed the basis for the 2021 classifications. So he chaired the CNS committee of for the International Collaboration on Cancer Reporting and was the founder and inaugural chief for C impact now. And of course, he was on the expert panel for the 2021 WHO classification. So a warm welcome to Professor David Louis to deliver his oration today evening in the ISNOCON 2022. Thank you so much, Dr. Louis, for accepting our invitation. And it's indeed an honor and privilege for us to hear you today. Thank you.
Thank you, Professor Sarkar, for that very kind introduction. Can you hear me? Can you
yes,
hear
sir,
me
we can
now?
hear you, sir. Yes, sir, we can hear you.
Oh, great. And can you see my screen yet?
So can I request you to make your slides full screen, sir? We can see your slides. But can I request you to full screen, sir? Yes, sir. Now it's full screen. Thank you so much.
Okay. Well, again, thank you, Professor Sarkar, for that kind introduction. And thank you for giving me the honor of being this year's Guha Orator. I knew Dr. Guha personally and knew him for many years, since he and I were trainees at about the same time. I first met him when I went over to the Brigham and Women's Hospital for a research discussion. He was spending some time with Peter Black at the time, and we were in a small meeting together of about 5 people, discussing some project. And afterwards, Ab and I walked out of the room together, and that started a friendship and some collaborations that lasted for many years. He was not only an impressive neurosurgeon and brain tumor scientist, he was also a very nice person. And he had a remarkable ability to pack large amounts of information into his presentation. So the challenge for me today is to try to put a fair amount of information into my lecture. I'll start by saying that the talk, not the last 2 talks, but the one just before that, was packed with information about the 2021 WHO classification. And so in order to save a little time, I've taken out some of the basic aspects of my talk. But what I'd like to do for you today is to take a big picture look at the 2021 classification. I realize that it's an audience that has not only pathologists, but oncologists and neurosurgeons, radiation oncologists. And so I'll try to make my talk not as much pathology oriented, but explore firstly, what are the big changes in the 2021 classification, and then spend a good amount of the talk on what are the problems that have been raised to me? What are the frequently asked questions about the classification that I've gotten? I've entitled the talk WHO CNS5. CNS5 is the 2021 classification, Climbing Up the Other Side of the Valley. And I'll explain to you what I mean by that. So before beginning, I like to begin all of my, before beginning on the 2021 classification, I like to begin all of my talks talking in general about why it's important to classify human tumors. For most of us, we relate to the care of individual patients, and we've just heard about this in a number of lectures, estimating prognosis and guiding therapy based on the pathological classification. But when you start thinking about it more, you realize, again, as we heard about in the last couple of presentations, the conduct and interpretation of clinical trials is also absolutely dependent on accurate classification. When you step back even further and think about experimental studies in mice or in petri dishes, again, if you incorrectly classify the cells or the tumors in that, you may derive incorrect conclusions that then may guide clinical trials in the wrong way. So even experimental studies are dependent on accurate classification. Stepping back even further, it's important to realize that population-based studies like epidemiology are ultimately dependent on accurate classification and coding of diseases, and that these types of epidemiological studies may actually implicate etiologies. And lastly, but not least, the allocation of resources by governments and health insurers to support healthcare is also dependent on accurate classification. As a result, the periodic revision of tumor classifications has diverse and important effects, many aspects of not only individual, but on population health. But it's also very important to realize that all tumor classifications are imperfect. They're imperfect representations, and they only reflect the state of understanding at a particular time and the interpretation of limited numbers of experts. They are very much to be thought of as works in progress. When it's thought, how do you get from basic biomedical research to understanding a clinical significance of something, and then put that clinical significance into practice? The analogy's been made to peaks and valleys. To get from basic biomedical research to understanding some clinical significance, you go through what's called Valley 1, and then to take that clinical information and translate it into routine care, you go through Valley 2. And these have been called the translational valleys of death. They're very hard to cross. I'll give you the example from my career. We first demonstrated in 1993 that gliomas could be subtyped genetically. But it was only in 1998 that we showed that 1p19q could subdivide oligodendrogliomas into those that were more responsive to therapy versus those that were less responsive. So showing some type of clinical relevance to a basic science discovery. It then took quite a while to develop tests and to begin to use the tests widely for clinical purposes. And it was only in 2014 that we began international discussions to use it for official classifications. And in the 2016 was the WHO was the first worldwide approval of use of a test that was a molecular test for classification. So you can see this is over 20 years from the time that a discovery is made until the time it's put into clinical practice. When you think of where the WHO classification lies, it lies in the second translational valley of death, right here. And so as we think about the challenges of implementing the WHO and making the changes for the WHO, we think about moving something from general clinical relevance to widespread practice. It's not only the WHO that participates in this. When you think about how we got from the 2016 WHO, which was the updated 4th edition, to the 2021 5th edition, it really was dependent on all of the activities of C-IMPACT. This was the consortium to inform molecular and practical approaches to CNS tumor taxonomy. So it's not simply, oh, 2016 happens and then 2021 happens. There's a large amount of debate that went on in between those two. So if you then ask, what are the major changes for the 5th edition for 2021? I like to divide them into general changes and specific changes. There are changes in the way the tumor classification is organized, its taxonomy, the way the tumors are named, the nomenclature. But what I'll speak to you right now about is tumor grading, the use of NOS and NEC, and integrated and layered diagnoses. So let's start with tumor grading. There have been some major changes. The first is the use of Arabic rather than Roman numerals. This seems like a silly minor change, but it's actually important. It will then make the CNS system conform with other WHO grading schemes for other tumor types. And it'll importantly decrease the likelihood of making a typographical error between a Roman numeral 1 and a Roman numeral 2 when grading within types. So what is grading within types? This is a key thing to understand no matter what subdiscipline of neuro-oncology you're in. As you heard about a couple of talks ago, we now think about astrocytoma IDH mutant as a single entity, and then within that entity, within that type, we grade it as 2, 3, or 4. This affects the nomenclature. For example, there is no more anaplastic astrocytoma. It just gets subsumed in the grade. The grade itself is now determined not only by histology, by molecular testing as well. For example, glioblastoma is also defined now by being IDH wild type and then getting a grade of 4, and we'll talk about this in a little while. Nonetheless, it's important to realize that it still is not strictly histopathological and molecular grading. There's a clinical component to it. And the reason that's so important is that, for example, when you look at astrocytoma IDH mutant, we don't begin with a grade 1. When you look at tumors in the rest of the body, if it's a malignancy, let's say a soft tissue sarcoma, once you call it a soft tissue sarcoma, it gets a grade of 1 if it's low grade, a grade of 2 if it's medium grade, a grade of 3 if it's high grade. But in the CNS, we've always reserved grade 1 for benign tumors like pilocytic astrocytomas. And so we didn't want to completely confuse the field, and therefore a tumor like astro-IDH mutant, there is no grade 1. It still is this clinico-pathological grading of 2 through 4. And that's why we've encouraged the use of the term CNS WHO grade rather than just WHO grade. It's not a pure clinical grading system because a tumor like germinoma is still grade 4 despite it being cured the majority of the time with radiation. And then we also said for the first time that in situations in which grade could confuse clinical practice, one can omit the grade. So for astrocytoma IDH mutant, you grade it from 2 to 4. Grade 2 has an IDH or IDH1 or IDH2 mutation. The tumor is well differentiated, it's diffusely infiltrative, and it lacks histological features of anaplasia like mitotic activity. And then it lacks microvascular proliferation necrosis and the molecular marker of CDKN2AB homozygous deletion. To go to grade 3, it usually begins to acquire anaplastic features histologically, just like we distinguish grade 3 from grade 2 in the past. And we also use significant mitotic activity. But the very high grade features of microvascular proliferation necrosis and the molecular high grade feature of CDKN2AB deletion are absent. And then for grade 4, which used to be what we called glioblastoma IDH mutant, one of those additional molecular or histological features are present: microvascular proliferation, necrosis, or the homozygous deletion. Contrast that with glioblastoma IDH wild type, which is defined as an IDH wild type diffuse astrocytic glioma with any one of these 5 features, 2 of them histological and 3 of them molecular. So again, the term glioblastoma now is reserved for an IDH wild type tumor. So it brings up this slight confusion. Is a tumor a glioblastoma or not? And if I were to say which slide in my whole talk is the most important, it's this one, because it illustrates the 2 scenarios that have changed the most between 2016 and 2021. So the first is a scenario in which you have a diffuse astrocytic glioma. It does not have microvascular proliferation or necrosis. So it's not what we might have called glioblastoma histologically in the past, but this tumor could be a glioblastoma if it has EGFR amplification, TERT promoter mutation, or +7 -10. That would be called an IDH wild-type glioblastoma, even though it's not histologically named a glioblastoma. And the opposite scenario is the one in which you've got a tumor with microvascular proliferation or necrosis, something in the past we would have called a glioblastoma. That in the 2021 is not a glioblastoma if it has an IDH mutation, because then it would be an astrocytoma IDH mutant, CNS WHO grade 4. And the reason we've separated these out is we now know that biologically, the tumors with IDH mutations are entirely different from those without. The goal is to clarify that when you do clinical trials, you have to separate out these entities. When you then begin to manage patients, you really have to think about these not as variations of a single entity, but really as different entities. The other key concepts are these ones of NOS, which is not otherwise specified, and NEC, which is not elsewhere classified. We didn't make up these terms. These are WHO terms, but we are now using them in very different ways in the 2021 classification. So I'll tell you about that and why the most effective way is to use them in these integrated and layered diagnoses. So let's talk about that for a moment. I like to think about NOS and NEC as this traffic light. If you've got an integrated WHO 2021 diagnosis, that is the histology and the molecular information all fit together. It fits, it looks exactly like it's described in the book. You go ahead and you make that diagnosis. But what if you don't have the tests available? You don't have access to the testing? What if that's the situation? In that case, you give it an NOS diagnosis, not otherwise specified, based on the histology. And this creates a red flag to the oncologist seeing the case, to the pathologist seeing the case next, that the case is not fully worked up. Now, it may be not fully worked up because one person couldn't order the test, but it may also be because you ordered the test and the test didn't work for some reason. NEC, on the other hand, not elsewhere classified, means that the necessary diagnostic testing was performed, but the results don't readily allow for a WHO diagnosis. This is what in the past we've called descriptive diagnoses, where it's very important for the pathologist to be in close contact with the treating doctors to explain what the more important aspects of the case are relative to the diagnosis. So NOS, NEC, and actual integrated WHO diagnoses are very important to understand, and there are distinctions between them that should guide care. We feel that the best way to show this is in what's called a layered diagnosis, where you have your integrated diagnosis, typically WHO, NOS, or NEC on the top, then the traditional histology, then the CNS WHO grade, and then the molecular information if it's available. So here's an example of an ependymoma, supratentorial. But when they tried to extract DNA from the formalin-fixed paraffin-embedded tissues, the DNA was not of sufficient quality for sequencing, and insufficient tissue remained for FISH studies. So you couldn't do the test, and therefore you label it NOS, and that alerts the clinician that it might be somewhat different from the typical supratentorial ependymoma that might have a fusion, for example. Here's another more complicated example. It's a diffuse low-grade glioma, MAP kinase pathway altered, and this had a specific molecular subtype of being FGFR1 TKD duplicated. Histologically, however, this looked like an oligodendroglioma. When you have such tumors, we're actually not exactly sure of the grade. So this is one that I mentioned you could not assign a grade. And then you list the molecular alteration. I hope that that makes sense to you, this notion of changing tumor grading, the importance of using NOS and NEC for any diagnosis. In 2016, it was reserved for specific diagnoses. Now you can use those terms as you need them, and to display these in integrated and layered diagnoses. So let's briefly go on and talk about specific changes within the tumor groups. And again, I've cut out some of this because of the very nice presentation we heard just about an hour ago on this. Usually when WHO classifications come out, most of the focus is on newly recognized types. These are obviously not new tumors biologically, but they're newly recognized. In the gliomas and the glioneuronal tumors, there are 14 of these entities, and you see them listed here. These are entities that were not in the 2016. And as you cast your eye over this, I won't go over them in detail, as you cast your eye over these, you realize that almost all of them are quite rare entities. That's important to understand. When you look at the other tumors, those that are not glial or glioneuronal, there are 8 new other tumors in the 2021 classification. You see them listed here, and again, all of these are quite rare tumors. The 3 tumors that are listed in italics are what we call provisional entities. There's good evidence that they are real, but not much evidence in the literature. So we expect them to be adapted as full entities as more data comes out on them. So let's talk about some of these. For the glial, glioneuronal, and neuronal tumors, there are 6 types. There are the diffuse ones, which are now divided into adult type and pediatric type. The type there is important to understand that these are not adult tumors and pediatric tumors, but they are adult type tumors and pediatric type tumors. The pediatric type ones are divided into low grade and high grade. And then there are the usual other groups of gliomas. These have been in the classifications for a long time: circumscribed astrocytic gliomas like pilocytics, glioneuronal and neuronal tumors, things like gangliogliomas or neurocytomas would be in here, and the ependymomas, of course. The major changes have been to these top groups. We now divide the gliomas into adult type and pediatric type. The pediatric type is divided into low grade and high grade. As I'll show you, we simplified the classification of the common adult type ones. And as I've already talked to you about, the nomenclature and grading of these common adult type diffuse astrocytic gliomas has changed. So if you look at those adult type diffuse gliomas, there are only 3. That's amazing. Astrocytoma IDH mutant, oligo IDH mutant and 1p19q co-deleted, and glioblastoma IDH wild type. For the pediatric type diffuse low-grade gliomas, there are 4 types. For the pediatric diffuse high-grade gliomas, there are also 4 types. So a rather limited number, but as I'll show you, there's a lot of diversity within the groups. So let's talk about the adult type diffuse gliomas. In 2016, there were over 20 entities listed in this category. Now there are only 3. The reason is we didn't list subtypes. Those are in the chapters. We didn't list the NOS types specifically because NOS and NEC can be used anywhere. The IDH assigns a diagnosis. It doesn't modify a diagnosis. We now grade within types, as I've described. The diffuse midline glioma has come out into the pediatric type high-grade diffuse gliomas, and oligoastrocytomas have now finally disappeared. So as a result, as a result, you only have these 3 entities left: astrocytoma IDH mutant with its 3 grades, 2, 3, and 4, oligo IDH mutant and 1p19q co-deleted with its 2 grades, 2 and 3, and then glioblastoma IDH wild type, only 1 grade, grade 4. When you look at these pediatric type diffuse low grade and diffuse high grade gliomas, I'll draw your attention to these 2: diffuse low grade glioma with MAP kinase pathway alteration and diffuse pediatric type high-grade glioma, H3 and IDH wild type. And I draw your attention there because these are interesting. These are rather nebulously named types, and each one requires further workup. So for the diffuse low-grade gliomas, you need to look at certain genes, and you need to exclude alterations of other genes. And for the pediatric high-grade ones, you need to do additional molecular examinations as well, including in some examples, you might have to go on to do methylome profiling. And I'll discuss methylome profiling in a moment. So the key points, therefore, are use the layered reporting format because it explains what have become complicated diagnoses. Use WHO diagnoses, and if it doesn't fit nicely into a WHO diagnosis, use NEC or NOS for the integrated diagnosis in the layered report. Grade within types now. And because this has gotten complicated, there are some good tables or flowcharts in recent publications, and I highly recommend using these until people get familiar both with generating these reports, but also as a treating oncologist, treating neurosurgeon, to understand these reports, look at these flowcharts. So I'm coming back to the diagram that I showed you at the start, which talked about Valley 2. And as I said, WHO is concerned with Valley 2, C-IMPACT is concerned with Valley 2. I don't have time to talk about the International Collaboration on Cancer Reporting, ICCR, which is also concerned with Valley 2. But moving up the other side of the valley is, it's a hard task. It feels like you're pushing a boulder up a very steep hill. And so what I thought I'd spend the rest of the talk trying to clarify is the process of pushing that boulder up the hill. How do you get people to use a new classification once it's been generated? And I'll answer two questions. What needs to be clarified and perhaps adjusted? And what are the structural barriers? So firstly, what needs to be clarified and perhaps adjusted? I rephrase this by asking, what are the most frequently asked questions, the FAQs, about implementing CNS5? And this is a personal experience. Since the publication late last year, I've gotten many emails and many questions at the ends of talks about struggles that people have had. And so what I've done here is to assemble those frequently asked questions, and I'll go through them with all of you. So I still get asked this a fair amount. What do I do if I don't have access to molecular testing? And the answer there is to use NOS. If your institution doesn't have it, and you see the use of NOS there, you'll know that there may be more information that can be derived from that tumor. What do I do if the histology and the molecular findings don't match to produce a clean WHO 2021 diagnosis? Well, again, that's when you use NEC, when things don't match. And I know I've mentioned this in the lecture, but I still get questions about this, so I think it's worth repeating. I then often get people saying, well, but NEC is not satisfying. I'd rather try to get it into a specific diagnosis. And my answer is yes, you're right. NEC is not satisfying, but in reality, it's much more honest than trying to force it, to shoehorn it into something that it is not. The treating clinician or the clinical trial needs to understand this is not a classical example of X or Y, and I may need to adjust my treatment, and I may need to reconsider whether this patient should actually be in the trial. So while I agree it's not satisfying, it's being quite honest. So if you don't have these molecular tests, but you can send them out for molecular testing, I get asked, if I send my cases out for IDH analysis and the results take a few weeks, is it true that a diagnosis of glioblastoma has to wait for a few weeks? Well, yes and no. The formal diagnosis, in fact, has to wait for IDH results, or else it's NOS. But preliminary diagnosis doesn't have to wait and should not wait. The pathologist should be communicating with the oncologists and letting them know that it's a grade 4 astrocytic tumor in most situations, and that will allow them to go ahead with treatment planning, even if you have to wait a while for the final actual diagnosis. Clinical trials, however, that require a diagnosis of glioblastoma will need to adjust their criteria going forward, and people have already begun to do this. From the clinical trialists, we've heard a lot of thanks for separating out these glioblastomas so clearly now and not confusing them with the IDH mutant tumors. So let's talk about a specific example I've gotten asked about a fair amount. How do I evaluate a grade 3 appearing tumor? So it looks like grade 3. It's anaplastic appearing, it's hypercellular, it's mitotically active, but it's IDH wild type. So it doesn't meet the histological criteria for glioblastoma, but it is IDH wild type. So there you have to evaluate for the molecular features of glioblastoma, and sometimes for the molecular features of other high-grade gliomas like H3. The molecular workup will often here clarify the grade. Is it grade 3 or grade 4? But if not, you just grade it on the basis of the histology, which would be a grade 3. What about this situation? This is, I think, the more tricky one. How do I evaluate a grade 2 appearing tumor? So it doesn't have anaplastic appearing cytology. It's not particular hypercellular. It doesn't have mitotic activity of any significant amount. It's diffuse, it's astrocytic, so you expect it to be IDH mutant, but instead it's IDH wild type. These are much more difficult than the last scenario I talked to you about. So this is really important that in young patients in particular, you need to evaluate them for the molecular changes of pediatric type diffuse low-grade gliomas. In our experience, these will sometimes turn out to have alterations like BRAF or like FGFR1. You then can also evaluate them for molecular features of glioblastoma, but in my experience, when it's grade 2, this is actually quite unusual to see frank glioblastoma molecular features. But if you do that and you don't find anything, either features of pediatric type or features of glioblastoma, then you designate it as NEC. And this acknowledges that the likely behavior is not well understood. We really don't understand these tumors. You can grade it then on the basis of the histology, give it a grade 2, and note that a clear grade has not been assigned by the WHO. Or you can simply avoid giving a grade and state that a clear grade has not been assigned. Again, the most important thing is clear communication between the pathologist and the treating physicians. This is another situation where the subject of methylome profiling comes up. Should you go ahead and try to do methylome profiling if you have it available? So I'll talk about how the WHO addressed methylome profiling, because I get asked this question a lot. We used it more as a discovery tool than a diagnostic tool. There are very few entities in the 2021 classification where you actually need methylome profiling to make a diagnosis. On the other hand, there are entities that were initially clarified in the literature through methylome profiling studies, but now there are alternative ways using histology and genetics to make that distinction. So what do you do if you don't have methylome profiling at your hospital? Well, you do the same as I do. I don't have methylome profiling at either of the hospitals that I oversee. We send it to another place. In our country, we send it to the National Cancer Institute, and there are a few other places around the country that'll do it, but the National Cancer Institute will do it for free for us. And so we send it out, and it's not widely available in our country. So if you can send it out, that's what you should do. Where do I think the future will go with methylome profiling? I think it's not going to replace standard diagnostics. It will find its niche, just like all other tissue-based techniques have over the past 100 years. When, for example, electron microscopy came out, or immunohistochemistry, there were fears that it would completely replace the way we do standard classification using the microscope. Similarly, molecular diagnostics and expression profiling was completely going to replace things. As people say now about methylome profiling, I don't believe that at all. I think there'll be specific instances where the pathologist will turn to methylome profiling, just like he or she currently turns to doing a FISH assay or some other immunohistochemical assay. And then I get asked the funny question, what do I think about methylome profiling? Because it's become quite a controversial issue. My opinion is that it's a powerful technique. I actually think it's very similar to histology for the following reasons. It was controversial and hard to use at first. If you look at the literature 100 years ago, in the 1920s and 30s, there was a big controversy about whether the microscope would catch on. Many people thought it was way too complicated to expect doctors to use a microscope to classify tumors, and that the gross appearance was more than sufficient. So similarly to the kinds of things that people are saying about methylome profiling now. It's also similar to histology because it analyzes thousands of variables, thousands of methylated loci in the genome, just like when the pathologist looks at a slide, he or she looks at thousands of different variables under the microscope. Individually, any of those are of unclear significance. There's no way any pathologist bases a diagnosis only on the mitoses, for example. And similarly, you can't base a methylome profile on only one area in the genome. That's very different from immunohistochemistry or a genetic analysis, which you look for a specific alteration. Is there an IDH mutation present or not? It's a yes, no kind of answer rather than an analysis of thousands of variables. Like histology, methylome profiling uses a brain to see patterns. In histology, it's a pathologist's brain. In methylome profiling, it's the brain of the computer doing some type of artificial intelligence to pull out the pattern. And that brain, whether it's a histology trainee, a pathology trainee, or the computer, must be trained to recognize patterns. And then lastly, it compares the findings with a reference set. You can't automatically say whether something's normal or abnormal. You have to compare a picture of the brain with a picture of the normal, a picture of a brain tumor with a picture of the normal brain to know whether the tumor is abnormal. Similarly, with methylome profiling, you need to compare it against all other profiles that are known in the literature. So that's the way I would encourage people to think about this new technology. It'll find its niche. I don't think it'll replace what we do. And in a sense, it's similar to histology. So let me ask you two questions to get your minds thinking about what I've discussed. Here's case one. It's a diffuse glioma. It's got an IDH mutation, ATRX loss, so sounds very astrocytic. No 1p19q deletion, so it sounds astrocytic. but there's no information about CDKN2AB homozygous deletion. So I've been asked, what do you call this? Is this astrocytoma IDH mutant NEC or NOS? And another case, what do you do if it's histologically grade 2 or 3, but it's IDH wild type, and you can't do the other molecular tests? Is that NEC or NOS? So if you take the first scenario, well, the most important thing that I said is you need to put a red flag on it. You need to tell anyone reading the report that it's not a classic, fully worked up example. The most important part is that the red flag is there to state that this is not a full 2021 WHO diagnosis. But case 1 has a clear diagnosis of an IDH mutant astrocytoma, and really all that is missing is the CDKN2A deletion information. That contributes to the grade, not really the diagnosis. So my preference, it's not a hard rule, but my preference would be to use NOS here, because all that's missing is a single molecular test and a final integrated grade. For the other example, again, the most important thing is stating what you know and adding that red flag, whether NOS or NEC. That's the most important aspect. In this case, however, it would be really important to look for other alterations like H3, like BRAF. And so the diagnosis in this situation is actually quite uncertain. And so I would have a strong preference in this case to use NOS. I've gotten asked, where in the report do histological variants go? Do they go in the integrated diagnosis or histology? I had a case recently of an IDH mutant astro. It was CNS WHO grade 4, no question, but it had giant cell phenotype and a primitive neuronal component. So you could put it in the integrated diagnosis as a subtype. So here you've got astro IDH mutant, CNS WHO grade 4, and put the subtypes in there. You list it as a high-grade diffuse astrocytoma with necrosis, it's grade 4, and you list the molecular alterations. Or you could put the histology under the histological classification and simply put it there. I actually don't have great preferences one way or the other. And that's the beauty of these layered reports, is that it actually doesn't matter that much whether you put it in the top or in the second line, because the person reading the report's going to see all of it. What do you do on a frozen section if it looks like a grade 4? In the past, we would just say glioblastoma. But now, if it's IDH mutant, in the long run, it's not going to be a glioblastoma. So what we say is diffuse astrocytic glioma, grade 4, await further workup, and that allows us more time. What do you do with the histological diagnosis for astro IDH mutant grade 4 if the histology looks like a glioblastoma? And wouldn't it be confusing if the top line said astrocytoma IDH mutant grade 4 and the second line said glioblastoma? So we don't use the term glioblastoma anymore for that histology. We say diffuse astrocytic glioma, and then we list the histological features that correlate with the highest grade. What do we do with the histological diagnosis for a GBM that's IDH wild type if the histology doesn't look like glioblastoma? Again, we just described the findings. From a diagnostic point of view, your diagnosis is in that integrated diagnosis line. The second line, which is histology, can be simply descriptive. So this is a verbatim question. Convincing new types of brain tumors are reported from time to time, but have not yet been included in the 2021 classification or have come out over the last year. Do I still need to report them as NEC, or do I use the terminology recommended in the published articles? And I would say both. Use the new term and also include what the diagnosis would be according to 2021 WHO, because the coders will find it very important to enter proper WHO diagnoses with the corresponding ICD-10 codes. I've been asked that pediatric type high-grade gliomas can occur in adults. The text does not provide age ranges. Yes, that's true. We use the term pediatric type, not pediatric. These tumors can occur in adults. It's just that they're more commonly found in children. Given the uncertainty about some of these rarer entities, we didn't provide age ranges, but it's hoped that future editions, as more are reported, that we'll have more information about that. Some of the essential diagnostic criteria, I've been told, are confusing. The principles seem different across different tumor types and chapters. This was the first WHO in which a single editor was not responsible for the overall book. There were multiple editors and each had a different section. This is just the way the new person running the WHO series has changed things. I personally thought it was not a good way to do things. And as a result, there is a lot of variability over the 2021 Blue Book, which was not the case in the past. So to me, this is the biggest problem with CNS5, resulted from a lack of a single responsible editor and how the final edits were made. Remember that early editions of the WHO, 79 and 93, were just definitions and illustrations, with the great majority of deliberation time being devoted to establishing these clear definitions. Right now, the WHO Blue Books are textbooks, and more time is spent filling in the details of the text than actually deliberating on the definitions. So this is a possible early topic for C-impact going forward. So will C-impact continue? I get asked this question a lot. Yes, the early stages have started under Peter Vesseling in the Netherlands. I'm not going to be the steering committee chair. We are currently working on steering committee and clinical advisory panel membership, currently working to assemble topics, and then we will assemble working groups. So in the interest of time, I will go quickly through the next part, but there are structural barriers to implementing some of this. There are relatively few studies of worldwide diagnostic capabilities, but there have been some very intelligent and creative adaptations after the 2016. I'll point to the one from India by Professor Santosh as the first author back in 2019. More research is needed in this area, and a colleague of mine from the UK, Henry Llewellyn, is diving into this in more detail. But I wanted to draw attention in the closing minutes to this really wonderful set of review articles that have come out by Drs. Sarkar, Uppin, and Mahadevan in the Indian Journal of Pathology and Microbiology. It's a whole special issue, and it looks at the 2021 classification, at its challenges and opportunities. And when I think about the best way to tackle these, I really can't do any better than what was put forth in this really excellent special issue. And I love the quotes, and so I wanted to quote them back to you. Every challenge contains within it the seeds of opportunity and growth. It is challenging to implement that. And what they write is that the major challenge relating to CNS5 is the practical applicability of classifications in low and middle income countries, where there's restricted availability of molecular testing facilities. It's becoming more and difficult over time to keep pace with these rapidly increasing markers. But then, very importantly, they add, how should we react to these challenges? There are two options: either fret over the lack of facilities, or take these challenges positively and turn them into opportunities to grow. I just love the way that's phrased. And three approaches are outlined. You can develop country region specific evidence-based guidelines. This is really brilliant. You can develop a few referral molecular diagnostic labs in a country. And the example that I gave you that there aren't any hospitals in Boston that can do methylome profiling. We use the laboratory in Washington, D.C. in the National Cancer Institute. So we're following option number 2 there. And then very importantly, to change the way training occurs in pathology so that pathologists are very comfortable with all of these new technologies. And what they conclude is that the molecular revolution shouldn't be taken as a threat to traditional histomorphology, which is what I believe. It should be taken as an opportunity for pathologists to accept their changing role and to expand their horizons. And then lastly, they quote the great Indian philosopher, and the philosopher says, "Let us not lower our goals to the level of our abilities. Instead, let us raise our abilities to the level of our goals." Truly an inspiring message in this situation. I won't go in, just because of lack of time, into details of what Henry is proposing, but it's important that in many places, particularly in Africa, it's not only that they don't have access to technologies, but they don't have access to basic aspects of what it takes to run a laboratory. And so Henry is going to be working to try to understand that, and what are some ways that countries that are really have limited, very lower abilities to do medical evaluations, how they can work as well. So I hope I've given you some indication of the problems, how questions are being answered, and how barriers are being overcome. And in concluding, I just want to thank all of the members of C-IMPACT over the past 5 or 6 years. C-IMPACT was a massive effort with many different people involved. And then to thank the other editors for CNS5. The editors are listed here, but there were many more authors, including some wonderful authorship from some of the colleagues here that are at this meeting. And with that, I will thank you all for your attention. I'll thank you for giving me the honor of a talk in Ab Guha's name. It really means a tremendous amount to me. Thank you.
Thank you, Dr. David Lewis. I think this was a really wonderful oration. And may I now request Dr. Kurkure to, Dr. Kurkure, can you, Dr. Chitra Sarkar, can you please come up? The plaque. So we have a e-plaque, but we also have a physical plaque that we will be sending to you, sir, when one of us actually visits the US or you come down to India. So can we have the plaque, please? The e-plaque, can we display the e-plaque?
Thank you. That's very kind. Thank you very much.
Thank you, Professor David Louis, for this wonderful oration and taking us through the whole WHO 2021 in a very remarkable way, answering the frequently asked questions which all of us have in our minds. And thank you very much for putting that editorial of mine, which made my day today. Thank you so much, and hoping to see you in India someday.
Thank you very much. Bye-bye.
Just a minute, Dr. David Louis. This is your plaque.
Oh, wonderful. It looks lovely from here.
So may I now request Dr. Roshni to conduct the proceedings?
Thank you so much. And after this wonderful session, now we move forward to our previous pending session on glioblastomas. And may I have the honor of inviting our esteemed chairperson, Dr. Sudhir Tyagi. And Dr. Sudhir Tyagi, Senior Consultant, Department of Neurosurgery at New Delhi. And Dr. Indu Bansal Agarwal, Director and Senior Consultant, Radiation Oncology at Narayana Hospital. I request the chairpersons to please invite the speakers on the stage.
So glioblastoma has always been a challenge when it comes to the treatment of this very aggressive tumor. So without wasting any time, we call our first speaker, Dr. Aliasgar Moiyadi. Dr. Aliasgar.
Hi, good evening, everyone. And thank you for staying back so long. And apologies for keeping you all till so late. If it's any consolation, I can promise you the talk will be very simple, far less complicated than all the talks we've heard so far, because I'm convinced now at the end of the day that neurosurgery is the simplest of things in neuro-oncology. So I think, how do I move this ahead? Okay. Okay, so what I'm going to talk about is how do we optimize surgery and what's the role of optimizing surgery in malignant gliomas. And I think the same can be extrapolated for low-grade gliomas. Dr. Gupta has given a wonderful talk. So all of us agree that the known and time-tested prognostic factors in gliomas and malignant gliomas are age, performance score, molecular profile, and we've heard a lot about it today, and then the treatment that you offer. And most of the studies, earlier studies which looked at adjuvant therapies in malignant gliomas realized that unless you control for and stratify for extent of resection, the results cannot be extrapolated. And therefore, extent of resection is a very important and a relevant prognostic marker. This was substantiated in a large meta-analysis and a systematic review, which actually qualitatively and quantitatively looked at the role of extent of resection in glioblastomas, and came out with the conclusion that there was, though no grade level 1 evidence, there was consistent and compelling evidence to back the role of extent of resection in malignant gliomas. The other question which has dogged neurosurgeons and which has been debated ad nauseum is how much should be removed. A lot of the controversy stemmed from the initial paper from Lacroix, which proposed that removing 98% of the tumor gave a prognostic benefit, but there was a lot of information between the lines which people missed. And subsequently, papers did come out over the next decade which showed that it's not just 98%, but it could even be 78%, for example, here, or even 75% and 70%. And what they showed, and this was summed up in this other paper, again from the same group, coincidentally, which Lacroix published from the MD Anderson group, that it does not matter whether you remove 100%. Any incremental increase in the extent of resection improves the prognosis for a patient with a given combination of prognostic factors. And this means that the more you remove, the better. Going a step ahead, we now also acknowledge that removing even more than 100%, and 100% has become a very relative figure now because it is a reflection of our limitation of assessing the delineation of the tumor. So we thought that all the contrast enhanced component is the tumor, but now we know that it's even beyond that, and removing all of that also is a prognostic benefit. So I think now it's very clear that the more you remove, the better. If you could remove 80%, then removing 70% is suboptimal. And therefore, you need to remove as much as is possible, but not at the cost of neurological morbidity. Now, coming to neurological morbidity, if I go back to historical data, you will see this table enumerates some of the older studies. And what is conspicuous is these are all surgical series, and that they never reported on morbidity. They reported mortality because that was the goal at that time, to save lives and avoid deaths. But as surgical technique and as technology advanced, the goalpost shifted from mortality prevention to morbidity prevention and improving functional outcomes. And therefore, I think it's very important to acknowledge that balancing extent of resection with morbidity is what gives the survival benefit. If you reduce the extent of resection or you increase the morbidity, both of them will impact survival. This extent of resection in morbidity and survival has a direct benefit, we are all aware. But also, and I think not many people would be overtly aware of this, is that when you have increased perioperative morbidity, there is enough in literature to show that that impacts survival because of various factors. And sometimes, and this is actually important, is that when you do a suboptimal resection, so your extent of resection has gone down, and this is what is called as the wounded glioma syndrome, especially in malignant gliomas, your morbidity also increases. So the act of doing a suboptimal resection can sometimes be a double-edged, not a double-edged, actually a two-pronged attack on reducing the survival. And therefore, you need to optimize the resection. However, the caveat, you can't do a heroic or an overzealous resection at the cost of giving more morbidity either, because that again is going to impact survival. So the key is to get an increased extent of resection with reduced morbidity, and this is what is going to optimize the survival. And this is the balancing act, and we've had everyone speaking about it. But I'd like to also highlight that it's not just the neurological morbidity, but also the neurocognitive morbidity. And therefore, the balancing act just got a little bigger and more complicated. But you need to understand that having an oncofunctional balance is the key. So if you step back a little and assess as neurosurgeons how we are doing, there are various challenges in achieving this balance, and all of us are aware of that. A combination of technique and technological adjuncts can be helpful in achieving this goal. There can be no substitute for microsurgical technique, and Dr. Aditya Gupta showed a very nice technical video. And I'm just going to, for the sake of completion, I'm going to say that a technique of subpile en bloc resection is a very oncologically relevant, rational, and a beneficial technique. However, it cannot be done in all cases, but wherever possible, it should be applied. But is that enough? So generally, you would apply that technique, and how neurosurgeons like us, what we would do is we would assess the extent of resection on table and say that this is removed completely. But we know that can be sometimes far from the truth. And this paper and many others actually have shown that there is a significant discordance between surgeon defined intraoperative subjective extent of resection and the postoperative objective MR assessed extent of resection, to the extent that there was tumor found in almost 70 to 75% of the cases where it was defined as an intraoperative gross total resection, which means that there is a significant gap between what you plan or what you anticipate and actually what you end up achieving. And this is where you need something to help you bridge the gap. And this is the technological adjuncts. And I'm going to just quickly go through all of them, hopefully in the next 5 minutes. Navigation, most neurosurgeons would be aware of. It's like a GPS system. It helps you locate where you are during surgery. But again, most neurosurgeons using it would also acknowledge that in intraaxial tumor surgery, there is probably a very limited role of pure navigation because of the problems of brain shift and resultant inaccuracy of the images. The gold standard for assessing resection extent intraoperatively would be intraoperative imaging, and the MRI, intraoperative MRI remains the gold standard. It allows you near real-time intraoperative imaging, and this has been shown in randomized study, though it was a small randomized study, and other studies and systematic reviews to have an impact, especially in low-grade gliomas. However, logistical challenges make this accessible to a very small proportion of neurosurgical centers.
On the other hand, you have the intraoperative ultrasound, and this is something that we use a lot. And there are different ways of doing the ultrasound, 2D and navigated 3D. And it, in our experience, which we've over the last decade or more, we've used both of these. And it seems to be useful for both low grades and high grades. And as an intraoperative tool to assess resection, it's, in our experience, we found that it actually impacts and changes the course of the surgery in almost half the cases, 43%. It prompted us to continue with the resection when we assessed the stage of the surgery when we thought we'd finished resecting. And with a very good diagnostic accuracy and concordance with postoperative detected residue. Moreover, the ultrasound, I feel, integrates very well with other surgical adjuncts, be it fluorescence, be it awake surgery or mapping and monitoring. That brings me to the next adjunct, and intraoperative fluorescence. Again, I won't go into details, but this basically lights up the tumor cells very specifically intraoperatively and helps you improve the resection, especially in high-grade gliomas. This is not objectively from any data in literature, but this is just an assessment, subjective assessment as to what would be the rough cost effectiveness of these techniques. And if you can see in high-grade gliomas, the ultrasound and the ALA seem to be a little better. Specifically, the intraoperative MRI does little lower the cost effectiveness, primarily for the reason of its exorbitant cost. There are other cheaper fluorophores which may make fluorescence a little more attractive, but they are not specific, and I think evidence still needs to be confirmed. Combining these adjuncts may be a useful option because one of them, like optical imaging fluorescence, is a surface phenomenon, and the others, like MRI or ultrasound, are topographic or sectional imaging, and they can give you complementary information. However, it's not just the tumor delineation that's important, but what you also need to ascertain often, not often, but many a times, is the eloquence. And usually these tumors are notorious for being in areas which are eloquent. And again, eloquent is a subjective definition, depending on what you consider as eloquent. I would say the whole of the brain is eloquent. So you need to be careful wherever you're operating. And that is why you need to assess the relationship of these tumors to eloquent regions before you go ahead to remove them. Now, there are ways to do this. Preoperatively, most of us would use fMRI, would use DTI imaging, and now you have transcranial magnetic stimulation, which is the most accurate to assess this, but that's not available. I think virtually nobody in neurosurgery would use that preoperatively, at least in India. However, the biggest fallacy of all these preoperative imaging adjuncts is that they can be inaccurate. And there are many reasons for this, technical as well as plasticity and individual variability amongst different patients. And this paper again showed why it could be so dangerous to label presumed eloquence as true eloquence, which means that when they looked at tumors and gliomas operated at their center and labeled it as per the preoperative MRI, and then they confirmed it intraoperatively with mapping and monitoring. I'll just take 2 minutes. Intraoperative monitoring, they found significant discrepancy, which actually resulted in differences in the overall survival, which means by labeling somebody falsely as eloquent on the preoperative MRI, you might do them disservice because you could actually have mapped intraoperatively, shown that it's not truly eloquent, resected better, and given a better prognosis to the patient. How do you do this intraoperatively? There are two broad ways, awake and asleep. Slight differences in the techniques and the expertise that you would need. There are different subcomponents and sub-techniques within doing this under anesthesia as well as under awake. And this is again, since it's not a neurosurgical talk or a neurosurgical crowd exclusively, I won't go into those details. To sum up, I think it would suffice to say that there is compelling evidence to show that extent of resection. I think there's unequivocal evidence to say that there is extent of resection is important. How that needs to be optimized is something which everyone has to individually, try and balance in their own practice. This is an algorithm that I would use depending on the resectability, tumor delineation, location, eloquence, and the intent of the surgery, which could be either resection or biopsy. A multimodal approach, judicious use of surgical technique, and proper application and choice of surgical adjuncts is the key to optimize these outcomes. As I said, not very complicated, quite simple to do. And that is my way of looking at it. The topic that was given to me is this: the summer and the winters that we are. It's a challenge, glioblastomas, malignant gliomas. I think even if we are not able to create or recreate summer and the winter, at least we can be better prepared for the winter. And that's what I think is actually imperative for all of us, neurosurgeons especially. And we should be optimizing the extent of resection, balancing that along with neurological morbidity. Thank you very much.
I think that was a really wonderful talk, and the key message that we get is that there has to be a onco-functional balance. And so I think all of us, we really enjoyed your talk, and I'm sorry we don't have any time for questions.
Okay, thank
so
you.
we will move on to the next session.
Thank you.
This is the last session of the day, and I know we are sitting between dinner and ghazal night and sleep. All of you must be tired, so we also have a general body meeting, yes. So now moving on to the next talk, which is by none other than Dr. Manmeet Ahluwalia, who is from Miami Cancer Institute of Baptist Health, USA. This is a pre-recorded talk, and the topic is improving outcomes beyond standard treatments. What has worked and what has not in GBM? Looking for that eureka moment.
I'm Manmeet Ahluwalia. I'm a medical oncologist at Miami Cancer Institute, and I would like to thank doctors Indu, Bansal, Aditya Gupta, Tejpal Gupta, and Rakesh Jalali and others for this kind invitation to talk about improving outcomes beyond standard treatment. Hi, good evening, everyone. I'm Manmeet Ahluwalia. I'm a medical oncologist at Miami Cancer Institute, and I would like to thank doctors Indu, Bansal, Aditya Gupta, Tejpal Gupta, and Rakesh Jalali and others for this kind invitation to talk about improving outcomes beyond standard treatments. What has worked and what is not in glioblastoma, looking for the eureka moment. And I've been asked to cover this topic in 15 minutes or less, so brace yourself for a roller coaster ride. This is my disclosure slide. This is the NCCN guidelines for glioblastoma. I'll go over most of the data that has led to these recommendations, and also in particularly some data in the last 2 years, either positive or negative. So this slide you have seen countless times, showed the benefit of temozolomide when given concurrently with radiation and adjuvantly over 6 cycles in newly diagnosed glioblastoma. That led to a 2.5-month overall survival benefit in everyone, primarily driven by a 6-month survival benefit in those patients who had MGMT promoter methylation, and there was a 21-day benefit in those patients who had an unmethylated. We also know that there is a 3-month progression-free survival benefit using tumor treating fields in addition to maintenance temozolomide, and a 5-month overall survival benefit with the combination compared to temozolomide alone. However, there is still limitation to uptake of this technology universally for a myriad of reasons. Phase 3 trial led through the EORTC mechanism showed that there was no benefit of addition of bevacizumab to lomustine. Those patients who were treated with lomustine alone did as well as those who were treated with lomustine and bevacizumab. Survivals in the ballpark of 9 months in recurrent glioblastoma. Despite this negative study, there was a full FDA approval given to bevacizumab in recurrent glioblastoma setting. We typically tend to use bevacizumab in patients who need high-dose steroids. This was the phase 2 REGOMA trial, which basically compared regorafenib compared to lomustine. Progression-free survival was similar in both the arms, but there was an overall survival benefit for regorafenib for 7.4 months compared to lomustine, which was 5.6 months. What is important to note here is that lomustine survival in this recurrent glioblastoma population was less than what we have typically seen in the EORTC study, a number of recent trials where lomustine is associated with an 8 to 10 month benefit. Regorafenib is being explored through the GBM agile mechanism, which I'll cover later in my presentation. 2 trials presented at ASCO 2022 that I would like to cover. First was the phase 2/3 trial of veliparib compared to placebo in combination with adjuvant temozolomide in newly diagnosed glioblastoma patients with MGMT promoter hypermethylation. This was the Alliance trial led by Jan Sarkari and colleagues. was unfortunately no benefit of Viliprib, which is a PARP inhibitor, compared to placebo in patients with MGMT promoter methylation. Both the groups had very similar overall survival. Viliprib treated patients had an overall survival of 28 months. Those treated with placebo had an overall survival of around 25 months. A second trial that was presented at ASCO that I would like to cover was this update from the INO 5401 and INO 9012. Basically, these are two DNA plasmids. INO 5401 is a DNA plasmid against human telomerase, Wills tumor 1 and PSMA. INO 9012 is a DNA plasmid against interleukin 12. These were then given in combinations with Semiplam, which is an anti-PD-1 drug in newly diagnosed glioblastoma. What was seen was that those patients who have unmethylated MGMT had survival of 17.9 months, and those patients who were methylated, cohort B patients, had a survival of 32.5 months. Both these look promising when we look at the historical benchmarks, but this obviously has to be validated in a prospective randomized trial. We know that EGFR is altered in 50% of patients with glioblastoma. Unfortunately, unlike lung cancer, where there has been a lot of benefit with EGFR inhibitors, we've not had that kind of success in glioblastoma. There are multiple reasons for that, including the difference in alterations, whether they are in the kinase domain or the extracellular domain, whether they are truncal or subclonal. Essentially, what we've seen are various approaches looking at small molecule tyrosine kinase inhibitors, monoclonal antibodies, and peptide-based vaccines have all been negative. And we are all aware of the data from Rindopepimet, also unfortunately being negative. More recently, we looked at antibody drug conjugates. This was an effort led out of the NRG group with Andy Lassman and colleagues, basically looking at Debatex-M, which is a monoclonal antibody that binds activated EGFR linked to a microtubule inhibitor toxin, basically using a Trojan horse approach. And here you can see no survival benefit with this approach, unfortunately. Despite this, there are a number of approaches being looked at with either fragment immunotoxins, nanotechnology, CAR T cells, BiTEs, BATs, newer ADCs, and intraarterial infusions still targeting the EGFR. Moving on to immunotherapy, as you know that in a number of other cancers, immunotherapy has been transformative. Unfortunately, in neuro-oncology, we've not had the same kind of groundbreaking results that others have seen. The only place where we have seen benefit with anti-PD-1 clearly is those who have a hypermutator burden because of germline biallelic mismatch repair deficiency, as shown by Eric Buffet and colleagues, that these are the kind of patients who can get benefit from immune checkpoint blockade. There were three large trials which looked at nivolumab. First one was the Checkmate 143, which was looking in recurrent glioblastoma. Basically, this trial showed that there was no benefit in overall survival with nivolumab compared to bevacizumab. Both the arms, median overall survival was around 10 months. Next was Checkmate 498. This is the study looking at nivolumab replacing temozolomide in newly diagnosed patients with unmethylated MGMT promoter and showing results that actually those patients who got radiation plus temozolomide actually did better compared to those who got nivo plus radiation with a hazard ratio of 1.31. Next was Checkmate 548. Here, nivolumab was combined with temozolomide and radiation, and again, no benefit seen with nivolumab in those patients who have MGMT promoter methylation. Those patients who got nivo had a survival median overall survival of 29 months compared to 32 months in those patients who got placebo. So all these three large trials have failed to show any benefit of anti-PD-1 in either newly diagnosed setting or recurrent glioblastoma setting. We looked at two different doses of bevacizumab to see if we could use bev in a two-prong approach in addition to nivolumab. This was a study I led when I was at Cleveland Clinic in collaboration with Dana Farber. And we wanted to look at a lower dose bev to maybe see if we could cause less of a response in these patients. But what we found was that there was very comparable survivals in both the arms of nivolumab at 10 milligrams per kg or 3 milligrams per per kg, and they were no different than what we had seen with those patients who were treated either with nivolumab alone or bevacizumab alone. But what we did find out was that looking at MDFC numbers, we could actually predict those patients who would respond versus those who would not respond. So patients who had a decrease in the MDSCs actually were more likely to respond compared to those where the MDSCs increased were the ones which did not respond. Also found when we did single cell RNA sequencing was that this MDSC effect was seen more in the standard dose BEV. Again, a small group of patients. We are trying to validate this in a larger cohort of patients. There was excitement about the neoadjuvant approach using anti-PD-1 before surgery in this effort led by Tim Clausey and colleagues. There is in a small trial, a benefit to survival with the neoadjuvant approach. Obviously, this needs to be validated in a larger setting. There are efforts looking at combinatorial approaches with neoadjuvant as well to see if we can take advantage of this approach. There are multiple strategies that are being explored to look at increasing the response rates of checkpoint inhibition in glioblastoma. These include addition of oncolytic viruses like the adenovirus through the purview of the captive trial. Initial results somewhat promising, definitely not a home run. They are looking at vaccines. They're looking definitely at tyrosine kinase inhibitors, lenvatinib being combined with pembrolizumab, CAR-T cell approaches, the EGFR V3 approach, plus pembro being led by Donald O'Rourke and colleagues at UPenn. There's definitely interest in looking at the IL-13 targeted CAR-T cells, and I already talked about the nivolumab antibody approach as well. Then there are efforts looking at whether can you combine the checkpoint inhibitors with radiation or laser interstitial thermotherapy or surgery, find avenues to improve the outcomes than what we've currently seen. These are results from Survaxem. This is a peptide-based vaccine against survivin. This was an effort that was done when I was at Cleveland Clinic along with Roswell Park as well as Dana-Farber, where we saw at least a promising overall survival of 26 months compared to the historical benchmarks. There's a large phase 2/3 study ongoing right now in the United States looking at this in randomized setting. We also are aware of recombinant poliovirus, 20% response rates in small group of patients in recurrent glioblastoma. Now this approach is being looked at in combinations with either alkylating agents like lomustine or anti-PD-1 agents. However, we have seen 20% response rates, at least in early trials, like with the TOCA 511, something that did not pan out in the large high-grade glioma recurrent study that was shown to be negative, unfortunately. The GBM Agile is a very nice platform to screen drugs effectively. As we know, glioblastoma is called the graveyard for drug development. So here, patients can be divided into unmethylated, methylated in the upfront setting and in the recurrent setting. And at least there is a very quick go, no-go approach. Regorafenib was the first drug being looked through this mechanism. Paxlovid and Val-083 are the other two drugs. There are two more drugs which are going to come through the pipeline through this mechanism. In top-down approach, one can look at different patients, then look for genomic alteration, then do biomarker-driven trial. And we did this through the INSIGHT mechanism that was led out of Dana-Farber. Abemaciclib showed some benefit in progression-free survival, need to wait for overall survival. CC115 was too toxic. So again, an effort in the right direction, but no home runs. If you look at precision medicine and bottom approach, here what we look at is we look at patients, but we look at those patients who do well and try to find out through biomarkers why someone is doing. We did this through the ABTC 1402 trial that I was involved with when I was at Cleveland Clinic. Here we looked at TRC102, which is a base excision repair inhibitor in combination with temozolomide in patients with first recurrence glioblastoma. Although there was no benefit in overall survival in all patients, we saw a survival benefit in MGMT methylated patients of 30+ months. So found out was a gene signature using RNA transcriptome. Those two patients who did exceptionally well had this particular gene signature that we do in a front trial that I've been involved with through the SWOG mechanism. Here we're going to look at an upfront study of TRC102 plus radiation and temozolomide in MGMT promoter methylation, and we'll also validate the DNA gene signature with the RNA transcriptome in a prospective manner. In the next few minutes, I want to talk about gene fusions as a very exciting potential therapeutic target in glioblastoma, someplace where we are actually seeing benefit. A great example of that is larotrectinib, which got a pan-tumor agnostic approval in NTRK gene fusion patients with the overall benefit of 80% response rates in primary CNS tumors. The response rates are in the ballpark of 36%. The entrectinib is a drug that targets the NTRK gene fusion and ROS1, and it has shown benefit in the CNS mets, but can also benefit primary CNS tumors. MET gene fusions present another exciting avenue in glioblastoma. APL101 is a gene that targets the MET gene fusion pathway, and the small study done in China showed at least in 6 patients with secondary glioblastoma who were treated with the APL101, 2 patients achieved PR and 2 achieved stable disease. This is being looked through an ongoing prospective trial that is being done in United States and Europe, looking at, again, APL101 in those patients who harbor the MET PTZ gene fusion. At ASCO 2022, the REGNAV trial was presented. This looked at a FGFR inhibitor called the edrafitinib. Was a 21% response rate in glioblastoma patients and high-grade glioma patients. Again, exciting news in a small group of patients. 3% or so patients with glioblastoma have the FGFR gene fusion. This is data from the ROAR study where they looked at combination of dabrafenib and trametinib in patients who have the BRAF V600 mutant low-grade and high-grade glioma. When you look at the grade 4 patients, there was 32% response rates with an overall survival of around 83 weeks. So what are the takeaways? Radiation and temozolomide followed by 6 cycles of adjuvant temozolomide is still the most commonly used approach. Addition of tumor treating fields gives you 3 months progression-free survival benefit and 5 months overall survival benefit. No therapy has shown any benefit in recurrent glioblastoma. Lomustine and bevacizumab are the most commonly used drugs in those patients who are not eligible for trials. Biomarker-driven trials and innovative clinical trial designs are going to be key for success in glioblastoma patients. Something I'm most excited about is these trials which are going to look at gene fusions, which I think are very durable and exciting targets. We are involved with a trial which is looking at FGFR in a very directed manner, looking at that patient population. Clinical trial enrollment, I think, is preferred way to treat patients, and multidisciplinary management is the key to achieving best outcomes in glioblastoma. Thank you all for this kind invitation to present this topic in front of you. Hope to see you in person next time. Thanks so much.
In next session, I'm inviting Dr. Nilesh Mahale and Dr. Sunita Ahlawat, who will be presenting the cases to find the solution to the riddle called GVM through molecular profiling. Dr. Nilesh and Dr. Sunita.
Good evening, friends. So this being last session, we'll try to finish it fast. This is a panel discussion about molecular profiling of glioblastoma. So we'll be briefly covering how radiology and pathology can be used for deciphering this riddle. So we are all aware about this famous picture done by our famous painter about 500 years back, the Da Vinci. Asha, can you roll the slides? Asha, before that, I would like to invite the panelists first. Dr. Prakash Chitalkar. Is it there? Dr. Sridhar, Dr. Aditya Gupta, please. Dr. Shaleen Kumar, Dr. Aliasgar, and Dr. Sona Pungat. So can you have the slides, please? Yeah, the next one. Yeah. So 500 years back, this picture was drawn, the famous picture, and we are still guessing what the lady wants to convey. Her gaze is full of all the riddle and the smile as well. So this is same with GBM. So we've been trying to find the solution to the famous riddle of GBM. So the major problem with managing the GBM and getting good survivals is the spatiotemporal heterogeneity. You know, because within a particular tumor, there are different clonogens and they behave differently. They have different molecular signatures and their response to treatment is different. And over a period of time, after the treatment, there is different natural history for different GBMs. So that is all. Let us see if it is reflected in the radiological picture phenotype and the pathological markers. So case 1 is a typical case of GBM. This is a 60-year-old man who presented with headache, vomiting, and left-sided weakness. So I would request Dr. Sona to comment on the MR findings of a typical GBM.
A well circumscribed lesion with the peripheral enhancement and central necrosis, disproportionate degree of edema in the right parieto-occipital region, and causing mass effect with early midline shift. So a necrotic tumor with, most likely it will show restricted diffusion in the periphery and hypoperfusion. So we're looking at a high grade and consistent with the glioblastoma. Yeah.
Yeah, so that's the regular picture. So based on this, as a clinician, we'll be interested to know if we can, based on MR, we can know about various molecular subtypes, like radiological phenotypes, whether we can know whether it is IDH mutated or wild or MGMT status, so that we can decide which particular therapy patient can be offered. Like if there is a limitation because of patient performance status or social factors, and whether we can use various other angiogenic inhibitors or other molecules.
So this would be a wild type, IDH wild type.
Yeah, I'll take you to some pictures here. So these are two different scenarios. On the top, you have one particular type, other than the bottom you have other type. Dr. Kumar can describe it, please.
So the lesion on the top looks like an infiltrative tumor which has a non-enhancing component and a central enhancement with necrosis and mild restriction at the enhancing component and some of the non-enhancing. So it's basically a tumor which is maybe transformed. So
yeah, on the top you have less of enhancement compared to that in a. Yeah.
And I think that's a cystic component, or maybe severe impending necrotic change in the medial aspect. And the lower one is showing an enhancing component with disproportionate edema with some pile enhancement, so maybe some pile extension and a high cellularity with low ADC values. Again, severe mass effect in both. So they are high grade, but one is IDH mutant and the other one is wild type.
So can you describe what a typical IDH mutant would look like against a wild type? Typical features.
So first would be the necrotic component would be larger in a wild type, and edema again would be larger in a wild type. And in the mutant, you would have an infiltrative component which would be larger with a small plus minus necrotic change. And perfusion wise, I think both would have high perfusion, but wild type would have higher.
Yeah. So
we don't get the 2HG on.
We get it on spectral. So higher 2HG would have the more pointing towards more mutant type, IDH mutant type. So Dr. Aditya Gupta, does it have any bearings on your management or deciding about surgery or extent of resection?
So basically, you see, when at surgery we find that tumor is very heterogeneous, I think it's easier to get lost. So as neurosurgeons, if you think a high-grade glioma is something which looks very vascular, fleshy, red or in dark color, it's very different from the normal tissue. And on the other hand, if it's very heterogeneous, for example, many a times we encounter low-grade like areas which are surrounding a high-grade glioma. So the point I would like to sort of learn from the pre-op assessment of whether it's IDH mutant or wild type is that one expects a very heterogeneous patient. when one is going into the surgery. Rather than just thinking it will be one morphologic type, which is very distinct from the normal brain tissue.
Right.
So if you expect a heterogeneous lesion to start with, then you can actually be more radical in your resection at the time of surgery.
So this would certainly help you in planning. Okay, Dr. Shaleen Kumar, you have anything comment upon this? Any bearings on the management, radiation wise, or deciding on adjuvant or concurrent temozolomide therapy based on pre-op MR findings?
I don't think so.
Because if you don't have access to the molecular markers, because we don't have it in all the places, in particular in periphery.
Sure.
So would you rely on these findings to some extent?
Well, if gross morphology tells us this is a glioblastoma, we just go by it. And just assume it's NOS, as was saying. I mean, we haven't done more, so it's NOS, GBM, and we just follow the STUP protocol, although the Catalan trial tells us otherwise, that it's not likely to work.
But it does have some implication. For example, it does look now, as we know, we don't call it glioblastoma, we call it now grade 4 astrocytoma.
Yes, sir.
So there could be a radiogenomic signature to it. And you don't need necessarily a 2HG to do it. Relatively non-enhancing, diffusely infiltrative with less ADC and less perfusion could point out to a grade 4 astrocytoma.
Right.
So you would act, a little bit more aggressively and give 12 cycles of adjuvant temozolomide rather than 6 cycles, because I guess you may not be able to do MGMT methylation also if they can't do an IDH.
Right.
But my strong suggestion is that every single lab should do IDH. It costs 1,000 rupees only. Your perfusion scan will cost 20,000 rupees.
Correct.
So please emphasize to your pathology labs to get at least IDH and ATR.
Yes, this radiology is no replacement for molecular markers, but it would help us explain the prognosis before we initiate any treatment. Because after surgery, patient and the family has a lot of expectation because they are told that maximum safe resection has been done. So they would expect a very good kind of survival.
The problem is in our country still, although it is changing rapidly, I think it's getting better and better. But still some people send for glioma markers or glioma panel, which is quite expensive.
Yeah.
Does 1Q19Q also for some reason without looking at the morphology. So that has to stop because the maximum cost is actually in the fish. Dr. Alawat will bear with me. But simply doing IDH and ATRX and P53 will settle the issue in a lot of patients.
Yes, she'll be talking about that minimum marker requirement. So these are other things, I mean, which can be predicted based on MR, but more established is only about IDH mutation. MGMT methylation can be predicted as a response to treatment. So once we initiate the radiation and concurrent chemotherapy, then we note certain changes. Dr. Jalali can explain more about it, the pseudoprogression versus and the implication of MGMT.
Everyone knows that pseudoprogression is higher in MGMT promoter methylated tumors and sometimes even in IDH mutant. So it has an implications. Every single enhancing nodule here and there should not be treated like a tumor. And we have learned over a period of time, the recurrences tend to be cortical, the treatment-related changes tend to be in the center towards the periventricular area. And we have seen it also sometimes people do surgeries or further radiation, so that has to be avoided.
So will the degree of contrast enhancement and heterogeneity or the edema surrounding the lesion help deciding about the bevacizumab use?
By the clinical, I think Dr. Manmeet also said we should not use it directly. There is some data that you should not use it with radiation because they will.
In the recurrent setting, sir?
In the recurrent setting, you should do, but primarily driven by clinical. If you can do it with a low dose steroids, it doesn't matter. As many times they are asymptomatic, but if they are steroid dependent, then you should introduce anti-VEGF therapies.
Okay. So this is how, I mean, now is the era of radiogenomics. So this is a typical slide showing how radiogenomics are being done. There is image acquisition via various sequences. Dr. Sona, can you comment on radiogenomics, how the data is expected?
So once all the sequences are collected and then co-registration is done, we process each sequence separately and try to superimpose each one on the other and try to extract the maximum information. And then there are more advanced steps which use more, we don't do it in our setting, but it goes into the laboratory where you do feature extraction, texture analysis and the central portions, and then it goes into artificial intelligence and data analytics.
Thank you. So I think Dr. Sunita will take over from here about markers. Okay.
Thank you. No, mine. Yeah. So today I had a minor accident. The talk that I prepared was not saved. So I had to make another, same talk, but all the slides could not be incorporated. But I'm going to give you good cases. So what I'm going to give you today is about tumors which have not read the book. And but we do have to treat them. So the first case is of okay. So about a 26-year-old man who presented in 2013 with a history of left side of body weak numbness for 1.5 months, diplopia. There was no history of seizures and no other relevant history. So let's go to this. This arrow. Only this. Okay. So as you can see that there is tumor in the ventricle, the third ventricle, and this was excised, and this was a classical ganglioglioma morphologically and on the IHC. And the patient went home, was doing well, post-op was uneventful, but he came back in 2017 with a recurrence in the same area. And this is the histology of the 2017 tumor. It showed a low grade area and a high grade area. The upper one is the low grade and the lower slide is of the high grade. You can see more blue small cells, which were, then you had endothelial proliferation and you had palisading necrosis. This, the key in the low grade is low and the high grade is very high, GFAP positive. ATRX is lost in the high grade area. The IDH was positive. So I thought those days where we were still standardizing IDH on IHC. So I thought maybe something wrong, maybe my IHC not, I thought this is an anaplastic ganglioglioma. But I sent for the molecular and it was by pyrosequencing, IDH1 or 132H was mutant. So we thought, ho gaya ye to, that time we used to call it as IDH mutant GBM. So P53 was mutant and this patient was treated for secondary GBM. But again, this fellow came back in 2019. And this time, the same morphology, GBM, and this time it is IDH negative even on molecular. And again, poor fellow was treated as per the protocol. And then he again came back just before the COVID in 2021, again with the same tumor, again IDH wild type, and in the same location. As we know that DBM, it changes places, it may become multicentric, but every time this tumor is occurring in the same location, and even molecularly it is becoming, it is heterogeneous. One day it was IDH mutant and now it is IDH wild type. And he was 26 when he had the first disease, that is in 2013. And now he's about 33-year-old, and every 2 years he's coming back. So may I have your opinion? How are you going to treat such a patient? Dr. Epari.
You only said they don't read, does not read the book. So you treat out of the book. So treat the current recurrence, treat like an IDH wild type glioblastoma, probably the location is such that of a diffuse midline type, treat it. That's the way I can say that bit, but I can't have any logical explanation of this switching the phenotypes. Probably in the hindsight, the first one, what we thought to be a ganglioglioma may not be a truly ganglioglioma. But even having said that, I can't explain.
I didn't think it was posterior third ventricle.
It is more thalamic. Yeah, it is more of thalamic location. And to be fair, to say that that location is very unusual for an IDH mutation. Very unusual. I mean, the way it has come, but still you have an evidence of IDH mutation.
No, even you also did.
I don't
The
have
patient
analysis.
went to you with both the blocks. The first one was ganglioglioma and the second one was
Have you done
IDH.
BRAF by any chance? BRAF
Yeah, BRAF has been done every time. All the time negative.
I have no answers to this one.
So
I think radiologically it doesn't look like ganglion. Looks like in the first picture, it looks like a malignant rectangle kind of picture. No, radiological.
Radiological,
Yeah.
yes.
But it was enhancing if that 2013 scan is really 2013.
Yes.
So which enhancing tumor will be there in a 26-year-old at that location? Cannot be grade 4 also because he has done so well, 8 years, 9 years. I did think of whether can it be a epithelioid GBM because they can enhance, they can have a relatively indolent, can be confused with ganglioglioma, but then BRAF V600 has to be positive and can be IDH negative. Then how do you explain IDH positive?
Epithelioid will have extremely poor prognosis.
No, some of them can go ahead with it. EGFR driven are very highly.
Oh no, we have done.
I mean, the problem is of the IDH positive. If that IDH positive we ignore, then it can fit in. But how do you explain that IDH positive mutant?
So should we think about it now that it has become IDH wild type?
It's unlikely. That's not
the.
Because that's a driver.
See, we know that nowadays the gliomas are multiclonal, but not to the extent of, because IDH is considered to be tumor initiating event. They're two different tumors. We can't explain the biological here. This will remain as an enigmatic case. We don't know and treat currently with the.
Okay. So going to the second case.
But madam, if a first at 2017 case, allele fraction was so high, tumor initiating event, subsequently you will not have it in a detectable way, difficult to explain. That means you mean to say in an IDH mutant tumor, there is a clonal evolution of IDH wild type? Ma'am, IDH mutant tumors, they have tumor initiating event. The allele frequency will be high. And to start it with high, and now if you have a tumor sample where lesser tumor sample probably had explanation of it, but you have done IHC earlier 132H and subsequently IHC is also negative.
Not twice the molecular.
We can have explanation so much. I don't know.
It started in 2013. It's more like ganglioglioma, which is undergoing a big change.
Because the GBM won't.
IDH, I just told him, I remember that there is a case report with ganglioglioma IDH positive.
Yes.
He just checked.
No, we did all that. We did all that. Do we have ganglioglioma showing IDH mutation?
One very lateral thought, which is not there, but I'm just thinking. 13, it was IDH positive case and was given radiation. Now it is a radiation-induced secondary glioblastoma, which is IDH negative. I'm just thinking aloud. This is the only thing I can think of.
Okay, yeah, and occurring on the same location again and again. Yeah. Okay, let's do the second one also, similarly exciting. So 42-year-old woman, left frontal, radiologically low-grade glioma. So morphologically look like oligo to us, with the subpile aggregation, perineuronal, and everything. Morphologically, oligo. So we thought we were looking at an oligo. So the GFAP was weakly positive, oligo positive, and ATRX retained, and IDH was wild type. I thought IHC only doing IDH1, so maybe the molecular will give me an answer. So we did the molecular, the IDH is wild type. Both 1 and 2 are not found. But 1p19q is co-deleted, TERT is mutant, MGMT methylated, and EGFR by fish is not amplified. So this is an IDH wild type, TERT mutant. How do we treat this? We treat it as GBM?
Clear-cut oligo, there is no doubt. Question is why IDH has not come positive? Sridhar.
Why it is not come positive? I have to say it's not come. See, when we talk about classical cases, we talk about classical cases. Here, see, if you are saying histologically so convincing oligo, and what Dr. Vaishali was elucidating in the previous case, the sample which you are subjected for pyrosequencing, you have to test the tumor percentage what it is. So the pyrosequencing has got a very good sensitivity. It can be just described in the literature as low as 1% also.
3 blocks.
No, I'm just telling you that way one way. Or the primer complex, what you are used for the pyrosequencing is a problem, something which we can think about it.
You also have done it.
So it's not that I'm error free.
No, but
I'm also error
you
prone.
and me both have done it. So both have found it negative on IHC as well as on sequence.
But
so I will believe this is
the
a
thing
true
is,
limit.
what I would advise most of the pathologists sitting out here or people who are doing molecular biology, when you're sending your sample for targeted sequencing or for single sequencing, you take your, most of the time we are doing it on paraffin-embedded tissue blocks, you take your sections for sequencing, like you've taken that paraffin-embedded tissue. After taking that tissue, do an HG, see that 70% of the tumor volume is there. So most of the times in our center also we are facing this issue, but now it is a standard protocol that we will not go in for sequencing if we have not seen the HG of that case after taking the sample.
That is the usual protocol in all the this thing. What I'm asking is the TERT mutation done after the IDH or before that?
We do a glioma panel, which includes everything.
So the reason, if you say that sample is adequate to pick up TERT mutation and was not adequate to pick up IDH, is difficult to explain the sample level.
No, you see, once the IDH came negative and there was a 1p19q co-deletion and there was TERT mutant, I sent another block for rechecking. I have, if I have 10 centimeter or a 5 centimeter of tumor, I process everything. Everything is put on the slide.
But that's not very convincing, like, to talk in a typical molecular canonical type of oligodendroglioma. Yes, the other subtypes are there. I mean, I don't know if you have done 1p19q.
So should we treat it as GBM or not?
No. I think
maybe we can't resolve this issue. But my question is, maybe the final question is that how would you treat it? So I think.
So TERT and 1p19q.
How should I report it? How should I report it? MEC, NOS.
You can't use NOS here because you have done everything. You say MEC. Or you have to do in ideal situation. In an ideal situation, TERT mutation is also described in pediatric type of tumors. Okay. So if you IDH wild type, forget about fish 1p19q because you are only seeing the small region. You are subjected to see the MAP kinase pathways, FGFR alteration, everything. If you rule out that, probably we can say that. But here at this point of time, are we really looking about adult type or not? Age-wise is fine, radiology-wise is fine. We will have an element of doubt in our mind. So in that context, you might use NOS, that it is not been completely investigated. But otherwise, if you feel, you can put it as.
You mean like diffuse leptomeningeal neuronal tumor in a child can have oligo, fish positive.
This is parenchymal, sir.
But it is 42-year-old.
But this is parenchymal.
42
young, sir.
Another
42
thing
young.
I would like to add is most of the centers we are doing fish, And we have seen that, like, we all use a cutoff of 40%, but sometimes it is very, very arbitrary in the sense like you get a deletion of say 45%, 50%, sometimes it is not whole arm loss. So unless you have a deletion of say more than 60%, I believe it should not be treated as taken as a diagnosis of oligo if IDH is wild type. So you have to be very sure that
third is also mutant.
So
Third is mutant,
no.
1992. No, and morphology also.
Dr.
Morphology is classic oligo.
Dr. Vaishali and Dr. Rakesh, I have a different take on 1p19q. If you are investigating 1p19q deletion, my sincere advice is it should be followed after IDH mutation. Because even the JITO, VICE, the best of the probes are not whole arm probes. They are the segment, kind of small loci probes. And they take very small reason. Most of the thing is 1p36 and 1q25 loci will be there. That is not the entire arm. It is only used as a proxy for detection of the arm loss. So that is why one fundamental thing is what Dr. Jalali was suggesting is, don't say subject the tissue like a glioma panel, like without knowing IDH and everything. We will have a problem in incorporating the details. Here, if you would have done array CGH and you would have shown 1p19 co-deletion, yes, it would have been difficult to explain. But fish-based 1p19 co-deletion, it is not equivalent of whole arm loss. Probably this is one of the phenomena of an total CMV, chromosomal number variation, which you have only targeted 1p and 19q, you picked it up. We don't know what it is. We are only just targeting. So difficult. So, third mutation, it is almost now ubiquitous. Like initially it came out with so much, I wanted to stress upon in the talk about that only. There is a lot of doubts emerging about its application as an isolated alteration. You have, here the radiology, morphology, everything is oligo. We are not able to explain IDH. In theoretically, when you are not having IDH mutation, yes, we should subject everything. I think Suvendu in the morning, he has elaborated in his talk about pediatric type of diffuse map kinase pathway. They can have typically oligo-like morphologies. They can have a diffuse infiltrating like morphology. And there are molecular subsets of these diffuse infiltrating things, but they are usually low grade. They are not high grade. Here you said it is higher grade, low grade only. So that always remains a possibility, like is it something, a pediatric type which has been long history and now you are detected.
So we should call it NOS and subject it for NGS.
Dr. Sunita, you have made the discussion very interesting. I think it will continue till the dinner. And let it continue also.
Can we just have the third case?
I think we might have time for the third case. We like to move to the next speaker. Thank you, panelists. I invite Dr. Anand Balasubramanian and Dr. Abhishek Chatterjee for the next talk.
Well, I think we are supposed to give just the pearls of what we have, some take-home message pearls of what we have discussed. So we have already seen what chaos can it create if you just do a straightaway glioma panel and if you just go in directly for multiple markers. So as Dr. Jalali mentioned, I think IDH is not very expensive. We have to do IDH for all tumors so that is the overarching classification, and then comes the rest of the markers. So for glioblastoma, that was what the last session was. Please get the IDH done, and that's more than enough for treating, because histomorphology is still the king. And we can do MGMT, probably that has a better treatment implication, especially in elderly. So these two are more than enough, and we did not have to confuse ourselves with too many other markers, at least from therapeutic or treatment point of view. Coming to the first talk which Ali gave for surgeons, I think it's very important for us to understand the onco-functional balance, which has been very well stressed by all the speakers. Most importantly, it's the attitude of the surgeon. It's not the adjunct that you use that is important. The surgeon should approach it with an idea of having a maximal safe resection to be achieved. If you're going to concentrate on good extent of resection and keep safety of patient in your mind, I think every one of us will use all the resources that we have, a good microscope, use of CUSA, use of monitoring, awake anesthesia, use of fluorescence if you have, ultrasound if you have. You can even use MRI, extraoperative if you are interested. Time is not a constraint here. Mind you, 2 hours you spend extra in the OR may amount to 2 weeks, 2 months, or even 2 years of extending patient's life. So I don't think we should be in a hurry to get out with gliomas. Spend all our time and work. And I would add one more point. Please, my request, do a post-operative MRI. You may not have intraoperative MRI, but it is the best learning experience all of us can have. What is the surgery we have done? Are we complete in what we have done? And how to learn and make it better is only possible if you do a post-operative MRI. We know there is constraint of finances, there is constraint of so many other things, but a post-operative MRI is imperative for you to learn and advance your techniques to benefit the patient better so that these patients can be treated better and better as days goes by. With these comments, I will end my talk and I'll ask Abhishek to come over.
Thank you, sir. I'll be brief. Can I have my slides? Yeah. So the problem with glioblastoma is both. What just happened? Yeah, the problem with glioblastoma is actually both the elephant and the room. So whatever we do, it represents a pragmatic strategy, but not really a winning strategy, because we have so many things to account for. We have achieved reasonable outcomes between 14 to 31 months of median survival with our existing therapies. And now that we have so many of these therapies on the right-hand side emerging on the horizon, what we need is more agility. So how do we get this agility? We have to remember that historically the treatments which have addressed glioblastoma heterogeneity best, glioma heterogeneity best, have done best. And TTF is actually one of these therapies which addresses the overall heterogeneity quite well. There's a need to harness it, therefore. We have seen a lot of disappointing results when it comes to immunotherapies, and this is where ex vivo immunotherapies such as CAR T cells and adaptive CAR T cells, which are not metabolically reprogrammed by the tumor, are likely to do better. Now, what will typically happen when we harness these new therapies is that we will get non-proportional hazards, and we will see something coming up on the post-hoc analyses, and these need quick elucidation. And this is where we need the rapid assessment of response and adaptation, where imaging, genomics via imaging, and liquid biopsies, and all these adjuncts are likely to help in the future, so that we can go through this loop faster and actually outdo the tumor in this loop. Thank you.
I think that was really quick and summed up everything so well. So now it's time for GBM. And I'm really very much impressed by the 60 people, more than 60 people still in the audience. And we started at 9 o'clock, 9:15, and it has been really a long day. So now I think it's time for GBM. And thank you for having us here.